It's my pleasure to welcome you all on behalf of Society of Fetal Medicine. Our today's webinar is totally dedicated to fetal therapy, which has come a long way since 1961 when the first intrauterine transfusion was done. Knowledge of fetal therapy is not only important for radiologists, fetal medicine specialists, but it's also very important for obstetricians because our ultimate aim is to take every fetus to its optimal outcome. Presently, number of fetal procedures are being carried out successfully in different parts of India. So we thought of having a virtual rendezvous with our fetal therapy experts. They are going to take us on an intrauterine tour and will show us how they salvage the fetus. I will not perorate more on that. It's time to welcome our revered seniors who are doyens in the field of fetal medicine. Because of limited time, I will be reading their CVs in short. Please forgive me for that. First and foremost, I invite Dr. Ashok Khurana sir, who is my mentor. As such, he needs no introduction, but I would love to introduce him formally. Sir is alumni of All India Institute of Medical Science and Delhi and trained at Harlev Hospital, Denmark. He is past president of Society of Fetal Medicine and is ESOG ambassador in India and also editor-in-chief of Fetal Medicine Journal. Now I welcome Dr. TLN Parveen sir. Sir is professor of radiology and currently president of Society of Fetal Medicine. His passion is to look at the fetus and to do invasive procedures. He has been bestowed with many awards and accolades and was past president of IFUMB and past vice president of IRIA. Warm welcome to Dr. S. Suresh sir, who is practicing fetal medicine for more than 40 years and has trained more than 5,000 doctors all over India and from abroad. He was conferred FRCOG in 2010. Sir has done pioneer work in cases of twins. He is ESOG Task Force member and also ambassador. Now I extend heartiest welcome to Dr. Pratima Radhakrishnan. She is director of Bangalore Fetal Medicine Center and FGI Research and Training Institute. She is the first Indian to have diploma in fetal medicine, first one to perform fetoscopic laser in India. Many more accolades to her name. I had privilege to be her student. She is very thorough and a passionate teacher. Dr. Vatsala ma'am, it's my privilege to welcome you. Ma'am is professor and chief of maternal fetal medicine at AIIMS. There are 130 publications and many more awards and honors to her name. Now, without wasting time, let us start our first session with Dr. Rima.
Thank you, Dr. Poonam. For the first session, without wasting much time, I invite our revered teacher, Dr. Vatsala Dadwal, one of the finest human beings. Dr. Aparna and Dr. Chinmay are two firebrands in fetal medicine. Dr. Aparna is very versatile and dynamic, and Dr. Chinmay is a fabulous orator, and her crispness comes from being an army officer's wife, and I take pride in it. I welcome both of you. Intrauterine transfusion, we understand, is, well, Dr. Aparna is here. Intrauterine transfusion is a treatment which is considered most successful for fetal anemia due to red cell alloimmunization. And we also use it for parvovirus, we use it for fetal-maternal hemorrhage, we use it for placental chorioangioma. I request Dr. Aparna to take us through the nuances of intrauterine transfusion.
So a very good evening to all of you and congratulations to SFM, Dr. Rima and Dr. Poonam Goyal for getting this, a really star-studded panel here today. I would start with the earliest and the most effective fetal intervention, which is the intrauterine transfusion. And when we talk about intrauterine transfusion, I would like to, say, why do we do intrauterine transfusion? And that is because of fetal anemia. right? And when we talk about fetal anemia, we know that immune fetal anemia is the most important cause of doing a transfusion. However, there are some things like atypical antigens. There could be other reasons like infections, TTTS, fetometal hemorrhage, and even placental chorioangioma. So today I'm going to take you through a basket of cases encompassing all of these together. So I would like to begin with my first case, which was a lady, 28-year-old, who was a resident of Haryana, who was referred to us at 24 weeks with a previous one normal delivery and one intrauterine fetal death. She did not receive anti-D in either of them. When she was investigated and worked up, her ICT was positive with 1 in 256. After a detailed workup, when we did the MCA PSV, it was found to be raised for that particular gestation, and we decided to do an intrauterine transfusion for her. So at starting from 24 weeks to 4 days, we did 5 intrauterine transfusions, the last one being done at 32 weeks and 6 days, in which the post-transfusion hematocrit came out to be 56. Following this, we followed her up and we delivered her at 36 weeks via cesarean section, and the baby's bilirubin was 5.9 and the hematocrit was 39%, following which the baby received 2 cycles of exchange transfusion and phototherapy. So this is the most common presentation that we do come across. And now I would like to take you through a video to actually show the nuances of fetal intrauterine transfusion. It's a gamut of cases putting together the important steps of fetal intrauterine transfusions at various stages, in various forms, and at various periods of gestations. So this is the step where we are actually taking the irradiated blood and preparing the patient for intrauterine transfusion. After this, we would like to give intramuscular vecuronium to paralyze the baby so that the baby does not move, and that can be given in the gluteal muscle or the deltoid. Now, this is the nice anterior placenta, which is generally the beginner's choice, and our trainees get to do this the first, if they want to do their first intrauterine transfusion with an anterior placenta. This is an anterior placenta. However, we did give the vecuronium, but the baby is moving. That becomes a bit of challenge. Unexpectedly the baby moves. But it's all about being steady and focusing the needle being there. This is again a posterior placenta, technically called as difficult, but this was one easy case where you have the actual access to the cord right there, and then you can transfuse very easily. This is another nightmare of a case where you have a posterior placenta, 18 weeks hydropic baby, where you have to do the transfusion. The cord is very thin, and yet you need to manage to do the transfusion at 18 weeks with a posterior placenta. And this is the cases where intravascular access is difficult, and we can do an intrahepatic transfusion sometimes in the early pregnancy. It is actually more preferable when you have the cord, which is very, very thin. So this is one of the cases where the intrauterine transfusion was done in early pregnancy. And this is another case where we do the intrauterine transfusion later on in gestation. So this was a very recent case where the intrahepatic transfusion was done towards the late pregnancy. Following the placement of the needle, we draw the blood, we push the blood inside according to the volume which has been calculated, and also depending on the pre-transfusion hematocrit. So this was a bit about the technique and the classical indications. I'll just take 1.5 minutes more and talk about some of the non-classical indications. And this particular lady is one of the cases that we have never really come across, which brought together transfusion medicine, fetal medicine, social service, and blood bank of Japan. So here this lady was in her 8th pregnancy, presented at 19 weeks, and she discharged only after she delivered in AIMS. She had eclampsia IUD first, high BP IUD second, high drops IUD third, Hydrops IUD 5th, again Hydrops IUD in the 6th when she first came to AIMS and turned out that her blood was incompatible with all blood groups. She was asked to avoid conception. However, she again had an abortion and then turned up to us in the index pregnancy. At the time of presentation, we first decided to give her IVIG because she was just 19 weeks. And despite the IVIG, the baby developed hydrops at 21 weeks when we had to transfuse blood, but there was no blood. So with the help of our transfusion medicine experts, we figured out that the blood that is needed for her is not exactly what we normally have. So Rh17 is a frequent antigen which is found, and if it is absent, then it becomes the D negative blood group, which is really, really rare. And if we actually look at the phenotype, it is this D negative phenotype which this patient had. And when we looked into the rare blood group registry, it is found in Japan in 1 lakh. No Indian data was available. So after contacting the rare blood group panel, we found in India there was 1 donor, and in Japan there were 32 donors. And the blood was imported from Japan with prerequisite documentation at a cost of 1.5 lakh per installment for transport, which we had to do 3 times. And then the patient was managed by intensive intrauterine transfusions. The hydrops settled after 3 transfusions, and 2 more transfusions were done. However, the patient was monitored, the mother and the baby were monitored, but at 31 weeks, the baby developed non-reassuring fetal heart, and a decision for emergency cesarean was taken. However, because there was no blood for the mother had to undergo autologous transfusion where we bled the patient before delivery and gave the blood back to her after delivery. The baby is doing fine now. So this was the 8th case overall in the world and first successful case of such a pregnancy in India. With each time there was a donation in Japan, import permits, payment initiation, patient transfer, and then IUT. So this was an experience of a very unique case that we had. Another indication for intrauterine transfusion that we saw 2 years back was a large placental chorioangioma with raised MCPSV in early pregnancy where the baby received 3 IUTs. And after that, the patient delivered at 31 weeks, and the baby required double volume exchange transfusion and phototherapy, a successful outcome following intrauterine transfusion. And the last case that I would like to present once more is a very recently who was referred to us at 30 weeks with raised MCA-PSV. She was a known case of Sjogren's with congenital heart block, already on hydroxychloroquine. So she had all the kinds of complications happening together. And because MCA-PSV was raised, we sent the parvovirus, which came out to be positive. On chordosynthesis, the baby had anemia. IUT was done at 31 weeks pregnancy. And this baby was delivered at 34 weeks with a successful outcome. So over the years or last 20 years, with experience of more than 1,200 to 1,300 intrauterine transfusion, about 100 transfusions are still being done at every month. However, the percentage being referred with hydrops has decreased. So I would like to acknowledge for this work here, Dr. Vatsala Dadwal, who's here, and the entire team of fetal medicine at AIMS. So with this, I would like to invite Dr. Rima to conduct the further sessions. Dr. Rima?
I think she's muted.
Dr. Rima, can you unmute?
Yes, right. Yeah. So, Dr. Chinmay, the question that comes up is that ICT for all, when to do, which is the right time of performing this test?
Okay, when we talk about the indirect Coombs test, that is the test which tells us whether a woman has antibodies against red cell antigens. And the commonest indication to do this is in rhesus negative mothers, where we do the ICT to look for anti-D antibodies. So in our practice, we do an ICT for every rhesus negative woman at the time of booking. Whenever we meet her for the first time in the antenatal clinic, we look for an ICT report. If it has not been done earlier, we do it at the time of booking. Because even if she's a primigravida, it makes sense for us to know that she does not have any antibodies to red cell antigens. So it should be done for every rhesus negative woman at the time of booking. If it is negative at the time of booking, then it is repeated again at 28 weeks of gestation, unless she's had any other, worrying events in between. So in a routine pregnancy, we would repeat it at 28 weeks and give her the antenatal anti-D for prophylaxis. And thereafter, we don't repeat the ICT. Once we have given the anti-D injection, we don't repeat the ICT. And then we repeat the anti-D at 34 weeks and after delivery. So that is a routine protocol. If a woman has an amniocentesis or any kind of invasive procedure, then we give an anti-D at that point and continue the routine prophylaxis after that as usual. If a woman has any suspected sensitizing event like a blunt trauma in the abdomen or bleeding per vaginum or with pain, then she is given excess another dose of anti-D at that point, and her routine prophylaxis also continues thereafter. Somehow in our unit, we do not repeat anti-D injection, ICT after giving anti-D injections, because it will lead to some positivity and therefore confusion.
Right. Thank you, Dr. Chinmay. But in spite of this anti-D being given for so many indications, we still have so much of RH immunization. Dr. Aparna just showed us the huge number of cases that they handle in AIMS. So what is the reason for this?
In fact, that's a very good question. And that's something we all need to understand, that while we are very excited with fetal therapy and we are very excited with these transfusions, the success of fetal medicine in this country would be if we had less number of transfusions to do. Because the very fact that women come with RH isoimmunization is a failure at some point in obstetric care. Now, one of the commonest reasons why women come isoimmunized is they have never received anti-D. Unawareness of this injection, unawareness of this protocol of checking the blood group and checking. You might find this very primitive in this discussion with ACE fetal medicine specialists in the audience. But let me tell you, I get only referral cases for fetal medicine opinions, and a large number of them come after IVF. I have seen patients at 22, 23, 24 weeks of gestation post IVF who don't know their blood groups. And because we don't accept any scan till we know the blood group, I mean, we do at least 32 to 35 blood groups per year for women who don't know their blood group despite having many fetal assessments. So checking the blood group is very important. And if a woman does not know her blood group and never reaches a center which asks for that, then she might be delivering somewhere in the periphery without any of this information. So that's one of the first and foremost reasons. The other reason is when we know anti-D has to be given, most of us give intramuscular injections in the gluteal region. And this anti-D injection is best absorbed when you give it in the deltoid region. So administration in a suboptimal site is one of the reasons why it will not be enough for covering the problems of rhesus isoimmunization. The other thing is, if you don't maintain a cold chain, then also the injection might become ineffective. And what kind of antibodies we are giving, and is the dose enough? Whatever we give, the 300 micrograms is enough for about some ml of blood that we are expecting that would have happened as a maternal to fetal transfusion during the process of delivery. But suppose the woman had a manual removal of placenta, or she had more bleeding prior to the delivery, she might have had excessive fetomaternal hemorrhage. So in an ideal setting, we should quantify the fetomaternal hemorrhage by like a test like a Clee or Batke, or if possible, flow cytometry, and then give the adequate dose. So these are the reasons why the rhesus isoimmunization may happen despite us having such, advanced techniques of fetal medicine in this day and age.
Thank you, Dr. Chinmay. So, Dr. Aparna, if the ICT is positive, indirect Coombs test is positive, what next? Do we repeat it? Do we give IVIG? Do we do an ultrasound? Can you tell us what would be the right way of handling this case?
Right. So I think this is the next step after what Dr. Chinmay has been doing and what we are missing out. So once the ICT is positive, it is important to understand if the critical titer has reached, which should be 1 in 8 to 1 in 16 in most of the labs. Now, if the critical titer has reached, we don't do any further ICTs. And now we know that the baby is going to maybe get affected. So we just need to do MCA Dopplers. And if at any point in time, the MCA is more than 1.5, then we either plan a delivery if the gestational age is more than 35, or if it is less than 35, then we go for an intrauterine transfusion. If, however, the critical titer is not reached, then we repeat so that means ICT is positive, but less than 1 in 8 or 16, then we repeat the critical titer, if it has reached the critical titer, and then manage accordingly.
Thank you, Dr. Aparna. But how much to give? That's a very important question. So, Dr. Chinmay, what is the amount of blood that you need to transfuse when you're planning intrauterine transfusion?
So the intrauterine transfusion is given to a fetus which is already anemic. So that fetus does have a lot of, hemodynamic challenge going on inside, and the heart of that fetus is pumping more to counteract that anemia, and therefore the amount of the volume of blood that we will transfuse has to be very appropriate. Now, what is different in fetal transfusion as opposed to adult transfusion is we compromise on the volume by increasing the hematocrit. So instead of a regular PCV pack that we have, the fetal blood packs are highly concentrated so that the hematocrit is very high. I mean, up to 70 to 80% also you could use that hematocrit to minimize the volume that has to be transfused. And like we are showing here on the slide, there is a formula to which you can adhere to calculate how much will be the requirement. So whatever is the desired hematocrit after the transfusion, and then the difference of what is the present hematocrit. How do we get the present hematocrit? With the first puncture that we make before the transfusion, a small amount of blood is aspirated, and that is immediately sent for a HemoQ examination to tell us what is the current hemoglobin and hematocrit status of the fetus. And we know what we are aiming at, and that calculation is made in the interim period while somebody already starts transfusion. Dr. Aparna just showed us how the transfusion is done. So we don't do a separate procedure to establish fetal hematocrit beforehand. What we do is when we start, this is done, and one of the team members goes and calculates that while the other person starts transfusing. So we try to minimize the volume by giving a high hematocrit, and then that replenishment is done after we have given the desired volume of blood that has gone inside and ensured that there's been no bradycardia or no cardiac compromise in the procedure as such. We aspirate a little bit of blood after, just before completing the transfusion, and then again checking that the desired hematocrit is reached.
Thank you, Dr. Chinmay. So, Dr. Aparna, how do you follow up these babies? Is it by MCA PSV or it's the rate of fall, 1%? How do you decide which modality to use?
Right. So for the first transfusion, obviously we depend on MCA PSV, but there are studies which say that, MCA PSV is not very good for subsequent transfusions. So definitely after 2 transfusions, we would rely more on rate of fall rather than MCA PSV. So we have enough studies to say that, MCA PSV might not be very sensitive after 2 transfusions. So a general of 1% per day fall, when it reaches less than 30, then we will transfuse.
So, Dr. Chinmay, of course, no intrauterine procedure is without complications. So, what are the complications that are anticipated while doing intrauterine transfusion?
So one of the commonest things, like what Dr. Aparna showed, was the access point. So you may not be able to access the cord easily, because if it's an anterior placenta, that is okay. But if it's a posterior placenta, she was very lucky to get an access on that cord like that, but sometimes it's very difficult to gain correct access, and therefore difficulty on multiple punctures going into different zones. That's one thing. The other thing is when you are transfusing, sometimes the fetus might go into a state of bradycardia, whether it's because of the pressure that you're putting while doing this procedure with the transducer and your hand and all that, or whether it's because of the hemodynamic changes that are happening. That's to be debated, but we can have that. Very rarely the woman might start having contractions, and you might have a situation where you may suddenly need to deliver the lady. So whenever you are transfusing in the 3rd trimester, it is imperative that you have covered her with steroids, and you are in a setting like an operation theater where immediately you can convert the transfusion into a delivery. And other complications like infections and preterm rupture of membranes, those will be common to all other invasive procedures.
Thank you, Dr. Chinmay. So, Dr. Aparna, when you talk of outcomes, could you tell us a little on the outcomes of this procedure?
Yes, so I actually started by saying that this is one of the most effective procedures, and that actually holds because the outcomes are quite good. So if you actually look at the world literature, overall survival is close to 90%. And even if it is hydropic with well-managed babies, the survival is good. So it is to be referred on time. And if it is referred on time, with hydrops, more than 95% survival, 90% survival, with hydrops also, it can be managed well.
Right. So thank you, Dr. Aparna.
Now,
I would request now Dr. Vatsala. She's doing a lot of cases and names with Dr. Aparna. I would ask her to give some expert comments on intrauterine transfusion. Dr. Vatsala, please.
Thank you, Rima. I think Aparna and Dr. Chinmay has covered the topic very good. But what I would like to reiterate is that prevention is better than management. So we should do the blood group for all antenatal patients. If they are Rh negative, non-IC immunized, husband is Rh positive, we should give anti-T, antepartum and postpartum. And of course, if the patient is IC immunized, refer to a center which can monitor them. We have a very good non-invasive tool for monitoring for detection of fetal anemia, that is peak systolic velocity of middle cerebral artery. And if the baby is thought to be anemic, then we can give intrauterine transfusion with very good results. Of course, there are challenges and complications to the procedure. So we still have some challenges as to how to follow the babies who have been transfused once, twice or thrice. Sometimes we have even done 4 to 8 transfusions in fetuses. So again, we go by the rate of fall and also look at the MCA-PSV. So this is one challenge, how to time subsequent transfusions. The other is the fetuses we get, or mothers we get who have had fetuses affected very early in previous pregnancy, like hydrops occurring in 20, 22 weeks. So we have tried IVIG for these patients. Sometimes it works, sometimes doesn't work. So that is a big challenge when you have to do intrauterine transfusion for very small babies. So when you're doing IUT for very small babies like 20, 23 weekers or hydropic babies, then we have to be very careful as to how much we transfuse. We should transfuse smaller amounts so that we don't increase the hematocrit to more than 25% or 4 times pre-transfusion levels, because significant hemodynamic changes can be harmful to the baby. So when you transfuse, you target for a hematocrit which is more like 45 to 50, which should be more in the physiological range. We don't want to over transfuse also, because polycythemia in the baby may also will be harmful. Again, how do these babies fare? So many of these babies will require exchange transfusion, phototherapy after birth. So that is also important. They require top-up transfusions in the first 3 months of life. And the Lotus trial has shown that almost 95% of these babies have good neurological outcome. So I think this is one of the biggest success story of fetal medicine and fetal interventions. Thank you, Dr. Rima. You're muted, Rima.
Yeah, thank you so much, Dr. Vatsala, Dr. Aparna, Dr. Chinmay for this wonderful session. We now move on to our next session. I would request Dr. Poonam to take this forward, please.
Thank you, Dr. Rima. Our next session is on pleural effusion. For that, I invite our very own President, Sir, Dr. TLN Praveen, as expert, Dr. Chanchal ma'am. She is fetal medicine specialist and lead consultant at Birthright Madhukar Rainbow Hospital, Delhi. And she is a very good orator and has authority on the subject. And Dr. Manikandan, who is bright, dynamic, young fetal therapist. He has been associate professor at JIPMER, and now he is working at his own center. His work is being appreciated by all. Now I invite Dr. Manikandan, please, for starting the case presentation and taking the session forward.
Thank you, madam. I will start the presentation of the case, and then as we go along, myself and Dr. Chanchal will answer your questions. So this patient we saw in early 2019, and she was referred to us at around 22 weeks for a second opinion for pleural effusion. Her previous history was significant in that the first baby was okay, but the second one was terminated because of heterotaxy and complex cardiac defects. So the couple were quite keen on salvaging this fetus. Otherwise, there were no medical risk factors. And when we did the scan, the rest of the anatomy was fine. And this is what we saw in the chest.
Dr. Chanchal?
Yeah.
How do we make a diagnosis of pleural effusion on ultrasound? And how would you differentiate it from pericardial effusion?
So, good evening, everyone. The diagnosis of pleural effusion on the ultrasound is quite straightforward. You see these anechoic spaces surrounding the lungs. Pericardial effusion will be contained by the pericardium and it will be surrounding the heart. So it's quite easy to distinguish and diagnose from the pericardial effusion. On the ultrasound, we need to see whether it is unilateral, whether it is bilateral, whether there is any mediastinal shift, whether there is if the pleural effusion can be because of congenital cystic adenomatoid malformation, whether it is because of that. So I think the ultrasound diagnosis of pleural effusion is quite straightforward.
Okay. So we went ahead and measured the volume. The cyst was obviously, the effusion was obviously causing a large mediastinal shift and in fact trying to cross the midline, and it was 23 cubic centimeter.
Dr. Chanchal, once you have confirmed your diagnosis of pleural effusion, what else you would look for in ultrasound, and how do we do the further workup for that fetus?
So once a pleural effusion has been diagnosed, half of them will have an associated malformation. So one needs to look at the baby one needs to do a detailed anomaly scan, which includes a fetal echocardiogram. One should specifically, as I mentioned, look for CPAM, any bronchopulmonary sequestration, diaphragmatic hernia, mediastinal tumors, and one needs to put on the pulse wave Doppler and look for arrhythmias. An amniocentesis should be offered because 10% of these may be associated with chromosomal abnormalities, especially Turner syndrome and Down syndrome. And one should offer testing for Noonan panel also, because that can be one of the presentations. Now, so as with any fetal abnormality or anything that we diagnose on ultrasound, the whole prognosis depends on whether it is an isolated condition or has associated problems. So the whole testing is directed towards that. If there is hydrops accompanying the effusion, one would want to do a blood group antibody screen, HP electrophoresis, and do a maternal TORCH, IgM, IgG. Look for MCA-PSP on the ultrasound to see whether the fetus is anemic or not. Now, the first step towards formulating an etiology of the effusion is to establish whether it is a congenital chylothorax, which is a primary hydrothorax, or is it secondary to infection. So there is a debate whether these large effusions one should straight away put in a shunt and do a diagnostic tap at the same time. But because almost 1/4 will disappear after a single tap, I think a more pragmatic approach would be to do a diagnostic tap, do a cytology for that fluid. Mostly the chylothorax will have more than 80% lymphocytes, which is suggestive of a primary effusion. And one would also look for protein, the way when we were interns. So we would used to do a cytic tap and send the fluid to distinguish between a transudate and exudate. The transudate would have mainly a cardiovascular pathology, whereas the exudate will point towards an inflammatory pathology. So the primary fetal hydrothorax, which are the correct candidates for a fetal therapy, that is actually a diagnosis of exclusion. So you look for everything, ensure that it is primary, and then go ahead.
Okay.
Dr. Mani, next slide, please.
Yeah, so that's what we gave the final diagnosis as the working diagnosis as primary left-sided massive with tension hydrothorax, and we offered essentially the same counseling, and we said we need amniocentesis, a pleural tap, and along with that TORCH PCR.
Dr. Mani, what are the concerns as a fetal physician when you see such a massive pleural effusion in a fetus?
Whenever there is a massive thoracic space outflowing lesion, whether it is a pleural effusion or a massive CPAM, cystic or otherwise, or a large mediastinal cyst, lymphangiomas, neuroenteric cyst, whatever may be the case, the concerns are Prenatally, it may lead on to hydrops because of cardiac compromise, venous return compromise. And postnatally, because of the long-standing space-occupying effect, it may lead to pulmonary hypoplasia, both of which can lead to increased mortality in the fetal neonate. And managing these two and mitigating these risks is the principal goal of prenatal management. So coming back to the case, because the baby was already 22 weeks, we went for a chordocentesis and the fish came back as normal. We discussed with the couple and they didn't want to go for more invasive tests as far as genetic testing are concerned. Viral PCR was negative, and following the pleural tap, the both lungs absolutely completely expanded, and you can see the image there. Lymphocytes were 86% and 28 ml was aspirated, which was close to what we calculated also. So we had a working diagnosis of primary chylothorax.
Dr. Manikandan, when should we offer fetal therapy? I mean, what are the indications and what are the contraindications of fetal therapy in these particular cases? Yes, as Dr. Chanchal correctly said, the good candidate is always a primary pleural effusion or what we call chylothorax. It has to become a tension hydrothorax. And I would also agree that one tap should be necessary to see if there is a regression following a single tap. That can happen in about 10 to 15% of the cases. The contraindication is when it is part of a non-immune hydrops. So there we don't touch it because the outcome is not going to be good. Bilateral is not a contraindication. Bilateral, if you think it is still primary, then you can still go ahead with the fetal therapy in the form of a shunt. But if it's part of non-immune hydrops, if there is a large cystic hygroma growing, and if there is enough evidence to say that it is secondary, then also we will not go. So in this case, after the initial diagnostic tap, we called her back in 48 hours, and this is what we had. Again, refilling, reaccumulation. It's a tension hydrothorax. You can see massive shift of the mediastinum. The lung is collapsed against the mediastinum. Contralateral lung is compressed. The diaphragm is now flattened out. So this is now a case where if you don't intervene, the outcome is going to be fatalistic. My guru is there in the expert. All fetal interventions are alternatives to fatalistic outcomes. So we are now sure that this is going to be a troublesome condition for the baby. So now this is a candidate for fetal intervention without question. Dr. Chanchal ma'am, how does one counsel the parents before deciding the fetal thoracoamniotic shunt?
So as with any intervention, counseling the parents appropriately is very important. First, we discuss with them the differentials and tell them that once it is a primary hydrothorax, and if it rapidly refills, as is happening in this case, the lung needs to grow, it needs to expand. And the main problem, without intervention, this fetus will have, it will evolve into a hydrops, or if it does indeed go up to term and delivers, there will be pulmonary hypoplasia. So this would be the ideal candidate for offering a fetal intervention in terms of shunting. Now, as with any intrauterine invasive procedure, there is about 20 to 30% risk of rupture of membranes, which can lead to premature delivery. The shunt can migrate. So if it is bilateral, one is expected to we place two shunts, one on either side, to drain it adequately. Now, the shunt failure can be either because it gets displaced inwards, or it can get obstructed, or it can come out into the uterine cavity, and that incidence is almost 10%. And that would warrant a repeat shunting. However, papers, published literature has not found any difference in the outcomes with repeat procedures. And as is mentioned in the slide, the reintervention does not affect fetal prognosis. The idea is to take off the pressure from the developing lung to allow it to expand and to prevent mediastinal shift, which will eventually lead to non-immune hydrops and polyhydramnios resulting in preterm delivery.
Dr. Chansal, what are the types of shunts which are available for thoracoamniotic shunting?
So in India, we used to get Rocket, which has somehow stopped coming now. So the Harrison shunt is the one that is used. There are a lot of papers from the Japanese groups where they have used these double basket shunts. However, in India, we have this Harrison shunt, which is available, and that is the one that is most commonly used. It's inserted through this 13-gauge needle. So the Rocket is in fact a little thicker. The inserter is thicker. So Harrison, the insertion is a little easier. So it's under ultrasound guidance. Dr. Mani will just show us the video of how it is to be inserted.
Dr. Mani, please go with the technicality of the steps.
Okay, so as with any procedure that we do, there must be a checklist that we should adhere to. The Society of Fetal Medicine is coming up with SOP for every procedure, so that's standardized. So this is for those who are starting their career in therapy. So have a checklist: pre-op, consent, antibiotic, xylocaine test, confirm the RS status, IV access, and we also give certain medications to prevent preterm labor that can be individualized according to your local practice. This is the tray setting. Here you can see atracurium and fentanyl, one of the questions in the previous one. And then usually we admit the patient so that overnight we observe, and then the next day they get discharged. So this is the video. It will be a 3.5 minutes video. I just run it here. So anterior, posterior views, and then this is the pre-shunt. By this time it is now 33 ml. So this is anterior placenta. So we gave the anesthesia via the cord entry. So that's the 22 spinal, choosing the vein instead of the artery, and then the anesthetic being given, streaming into the umbilical vein. So the baby becomes quiet, and it is essential that when we do a fetal procedure which involves entering the fetus, after 20 weeks, we give fentanyl because the baby can perceive pain. If you are going for transfusion into the cord, then it's not required. We just immobilize the baby. Needle is out. And now you can see on the far right corner in the screen, the 13 gauge introduce a needle, enters the amniotic cavity. The entry must be brisk so that you don't tent the membrane. And then the position, you can see that I put 3 tips here. The first is subscapular. So you should come to the thoracic cage on the side of the effusion and enter below the scapula. That's the place least likely to be removed by the baby itself. Otherwise, the baby will keep searching and then it will remove the shunt after some time. So you can see that if the position is not straight away favorable, you can gently turn the baby. Under anesthesia, baby will obey. And then you can see the scapula was seen, and then I've just gone below the scapula. So the problem with placing such a big needle is that there is no counter traction to give. So you have to go with a very brisk jerk into the pleural cavity. Once the pleural cavity has been entered, then you remove the operator of the needle. Here, the other tip is, once you remove the operator, because it will be under so much pressure, the fluid will all come out quickly. So you have to close it with your thumb, the needle hub. You have to close the needle hub with your thumb. Only then you should ask the assistant to load the coil catheter, because the catheter has what is called as the memory. If you load it long before, then the memory will be shortened and it may not coil. It has to coil inside and outside. So in order to facilitate the retention of memory, load the catheter onto the guide wire only after you have entered, and then you have closed the hub. Now I have deployed the inside coil and then removed the needle but holding the positioner inside, so that the second coil is now outside the baby. The outside coil will be 2, inside coil will be 1. That is how the Harrison shunt is designed. So that's because it should not migrate inside. It can come outside, that's fine. So this is the positioning confirmed after the final deployment. And you can see that it is compacted and sitting just below the scapula. Immediately post shunt, you will see that fluid comes out in a rush, and after the first bout comes out, the volume decreased to about 10 cc. In the first week, the shunt was very much in position and the lung had expanded well. 4 weeks later, again, both lungs expanded well and no evidence of pleural effusion, but the shunt had migrated and we found it freely floating in the amniotic cavity. We reassured her, we said, okay, the lung is expanded, so it must exert some pressure and able to stop any more leakage. Fortunately, that happened and the lung remained expanded. By 38 weeks, she was delivered, vaginal delivery, and baby was doing well. Certain things in the peripartum management should be communicated to the delivery team, that is the obstetric team, because they should be prepared. If the shunt were to be in place, then the neonatal team should be ready to clamp the shunt at the time before the first breath, so that pneumothorax is avoided. Otherwise, rest remains the same. Any lung issue, preferred mode of delivery is vaginal.
Dr. Chanchal, how effective is the fetal therapy in pleural effusion? What is your experience?
Yeah. So, I mean, my experience is very limited, but from the literature, what is given is that as almost 1/4 may resolve after the first tap. The ones who have high drops are unlikely to resolve. Even with high drops, if there is shunting, the survival jumps from just about 60% to more than 90%. So fetal therapy is effective in carefully selected patients in whom shunting should be offered. You can see from we've collated this data that with untreated the survival, even without high drops, they do survive. However, the survival is much better with once they are offered intervention. So yeah, this is the second slide. So with thoracoamniotic shunt, even hydropic babies, the recent literature, they have quoted that the survival is much better.
Yes, I think it's about 90%.
90%. Yeah, even with high drops, it's nearly 90%.
Without treatment, it's about 50%. And if you put in a shunt, it's 90%.
Yeah. So one point I would just like to make is that the shunting, it also decided by the gestational age at which the pleural effusion occurs. So if we are far from term, I mean, if it is less than 28 weeks, one would be more inclined to put in a shunt because it is a more permanent measure. If it is closer to 32 weeks, maybe the patient will need 1 or 2 therapeutic taps to drain. And if a shunt has migrated or has not been inserted and the pleural effusion reaccumulates just before delivery, even if they are being, if they're in the OT pre-delivery, drainage of the effusion is recommended because it makes resuscitation of the fetus much more easier. The neonatal resuscitation is better.
One point about the gestational ages, I take a cutoff of 32 weeks.
Yes.
Once you cross that, you go to 32, 32 through 33 weeks or 34 weeks. Technically, the shunt insertion into the thick thoracic wall becomes difficult. You keep prodding, the baby keeps moving, it doesn't pierce as well.
Yes.
And it's a younger fetus. So I keep it at 32. If it's above 32, if the presentation above 32, then serial thoracocentesis.
Yes, yes. Yeah.
Now, just to summarize what we have gathered from our 2 fetal therapy experts, that it is suitable for large fluid-based SOL in thorax. It improves in utero and ex utero survival, and case selection is very, very important. And the prognosis is good. It all depends upon the gestation age, as Dr. Mani just explained. Then resolution of hydrops is also important. Complete drainage has been done or large reduction in the size has occurred. or the disease is unilateral, then the prognosis is definitely better.
And
Now,
regarding
I would
shunt migration, there is a paper in exclusively those in which the shunt migrated. So from the Gregdine group, they spoke about somebody who's now 20 years old and has a shunt which migrated into the lung and it doesn't warrant removal. So that was very surprising.
So now I invite Dr. TLN Parveen sir for his expert and concluding comments on all this. Sir, please.
Yeah, thank you. Good evening, everybody. Thanks, Dr. Poonam Goel. And it was very well conducted. And I congratulate Chanchal as well as Manikandan for presenting this wonderful case and taking us through various aspects of the procedure, as well as the do's and don'ts, and at the same time, how to sell it. Basically, there are two things that we need to be very cautious about. One is to identify whether it is a primary or it's a secondary, because that makes a lot of difference as far as planning the therapy. Second most important thing is to differentiate between the initially itself between a pleural effusion and a pericardial effusion. Classically, when there is a pericardial effusion, you see that both the lungs are plastered posteriorly, just looking like a bat's wing. So that's a classical description of a pericardial effusion rather than a pleural effusion rather than a pericardial effusion. And then we have once the differential diagnosis is established and it is isolated, particularly when we know that it could be a congenital chylothorax, it is ideal to do the shunt procedures. There are some alternate procedures, and most important thing when we do all these procedures, the basic concept is to avoid pulmonary hyperplasia, because pulmonary hyperplasia is the most important thing that is going to cause a lot of problems to the fetus as well as the neonate. So keeping these things in mind, now we have been taken through various procedures, various aspects of it: diagnosis, management, planning of the management, and the different types of shunts that are available. And of course, the Harrison shunt is the one which is now available, but it is only 5 French. Quite often, the literature says that there are a lot of obliterations or they get blocked. Whereas the rocket shunt is almost 9 French. And this double basket appears very, very interesting and very useful because it's a single puncture procedure where you can just put the trocar, load the double basket and push it in, and then leave the other side of the basket into the amniotic fluid. But we have no experience about it. So I think with this as a whole, it has been very enlightening that we do come across this sort of pleural effusions quite often. And we now know how to counsel these patients and what are the outcomes by intervening these patients. Thank you very much. I think it was a wonderful session.
Thank you, sir. Dr. Rima, please take over for the next session. Dr. Rima?
Yeah, so we have the trade videos now. I would
Okay.
request the trade videos
Yes,
to be
before
played. Good evening, everybody. We're back after the break. For this session, let me invite Dr. Suresh. He needs no introduction. He's been introduced. And let me tell you, we in fetal therapy, like Karan, hold him as our guru, even if we are not Arjuns to be working with him. I invite Sir, Dr. Vatsala. She's been my teacher and guide. And in all difficult cases, she's there all the time to help. Dr. Chandra Lula, I would request, Dr. Chandra Lula is a very powerful orator. He's got many feathers in his cap and we all love to hear him at all conferences. We welcome you, Dr. Chandra Lula. He has been ex-president of so many different professional bodies. It's amazing. Can we move to the next slide, please? Now I welcome our energetic and conscientious fetal medicine specialist, Dr. Vivek from Amrita Group of Hospitals. He's meticulous and he's done some fantastic work, written some books, and he's very cool, calm, and composed. We welcome you, Dr. Vivek. And I welcome Dr. Sineesh from ARMS Aegis Hospital. He's another young, bright, and very energetic fetal medicine specialists. It's great to have such a fabulous panel today for us to take twin pregnancy forward, which I understand is a very difficult problem. Monochorionic twins, we shall focus on, has a lot of complications like TRAP, TTTS, TAP, selective growth restriction, and all of them are a dilemma to handle. And the main problem in them is there's this discordance of the blood flows between the arteriovenous and the veno-arterial blood flows. There's discordance in placental territories. There's discordance in fetal defects. This leads to TTTS. It leads to TAPS. It leads to selective growth restriction. And all of this is very, very problematic because if one twin dies in utero, it causes neurological damage in the other twin. And that is why handling these cases, referring them at the right time to the fetal therapy specialist becomes extremely important. So I would, we move forward with Dr. Vatsala asking the first question as to what are the different indications for fetal reduction in monochorionic twins and what are the different techniques that we can use to handle these babies.
Good evening, everyone. Thank you, Dr. Rima. So Dr. Rima has already highlighted a list of complications which occur and are very peculiar to monochorionic twins. What we need to understand is because of all these complications, one twin may get sick or compromised in utero and maybe sort of heading for an imminent death. So if the pregnancy is remote from term and we deliver, then we jeopardize the healthy twin. So in some cases, we may have to reduce the unhealthy or the sick baby to let the other baby continue. And again here, we cannot use KCL for reduction. So we have to use cord occlusion techniques. Because of the vascular anastomosis, we cannot use KCL. So of the cord occlusion techniques, what we're commonly using are the radiofrequency ablation and bipolar cord coagulation. So I would be discussing about these two methods. So let me take you through the first case. So this patient was a spontaneous conception, was referred to us with a very anxious patient and equally anxious gynecologist. So this patient was 25 weeks pregnant and she came to us with the ultrasound report. So the first baby was small and the estimated weight was at 8.6 centile and all the parameters were less than 1 centile. The other baby was growing well. And if you look at compare the two, there was a 44% discordancy. So when we did the Doppler, the smaller twin had persistent reverse flow in the umbilical artery and the normal twin had normal flow. So both the patient and her obstetrician are very concerned because this was just 25 weeks pregnancy and they just wanted to know what is to be done to save at least one of the babies. Dr. Rima.
I'm sorry, Dr. Chandrula, could you tell us how do we classify selective growth restricted babies? What is the classification that tells us how do we manage these babies?
Yes, so the classification is based on Doppler. Essentially, as you can see on the screen, there are three categories. It is type 1, where there is a Doppler which may be slightly showing high resistance or it may be normal. Type 2 is where, as in this case, you're seeing reversed end diastolic flow, so absent or reversed end diastolic flow. And type 3 is the most unstable form where you have intermittent absent or reversed end diastolic flow or absent diastolic flow, where you have to scan over a period of time to actually pick this up. It may not be apparent initially. And in both these last two categories, the prognosis can be guarded, especially in the type 3, you can have a sudden fetal death, whereas in the type 2, you can prolong the pregnancy and deliver it in appropriate time.
Thank you, sir. And so Dr. Sinesh, Dr. Chandrula did mention, could you just elaborate a little on the prognosis of the two type 2 and type 3 selective growth restricted babies?
Yes, Rima ma'am, thank you for the wonderful introduction. Now, once the SFGR falls into type 2 and type 3 categories, the prognosis becomes a little worse. So specifically, the prognosis is worse in type 2, where almost 90% cases undergo Doppler deterioration before 30 weeks. Consequently, the perinatal mortality and the morbidity is much higher in this group. Nearly one third of the smaller fetuses survive, whereas the survival for the larger fetus is about half. And even in spite of survival, around 10 to 13% fetuses may undergo neurological damage as well. Now, type 3 has a slightly improved outcome, but there the situation is an unpredictable demise in the smaller fetus despite proper or adequate surveillance. And ironically, the greatest incidence of neurological damage is actually seen in the larger fetus of the order of around 15 to 30%. So these are the issues seen in type 2 and type 3 SFGRs.
Thank you, Dr. Sunish. So now I would request Dr. Vatsala to tell us that since it's a huge problem with these monochorionic twins with selective growth restriction, what are the management options that are available with us?
So the couple were counseled about the poor prognosis. If we continue the pregnancy, very likelihood of the smaller baby dying in utero and all the complications. So if, so type 1 usually does well, may not require any interventions. Type 2 and 3, if it is, the disease is severe, that is occurring at less than 24 weeks, there is more than 35% discordancy, oligohydramnios in the smaller twin, then there is a role of active management, and that would be selective reduction of the smaller twin. So this was offered to the couple, and the risk and the benefits explained, and they agreed to undergo the procedure. So we did a RFA for this patient. So this is the RFA machine that is used to generate the current, which is passed through the tines so the temperature rises and the tissues get coagulated, and that's how the blood flow is blocked. So as for any procedure, you need to take consent, informed consent. We need to we usually do it under sedation with proper asepsis. The patients are prepped. And because we're using electric current, we have to use dispersive electrodes also. And we usually do the procedure under sedation. So this is a small video showing the procedure. So first of all, we do an ultrasound to localize the point of entry. And under ultrasound guidance, a 17 gauge RFA needle is introduced. The needle we used is around 12 centimeters in length with side deploying tines. So once you're through the anterior abdominal wall, the uterine wall, we try to avoid the placenta, but in this case, it was not possible because the baby was here all stuck to the placenta without any liquor. Then we enter the fetus at a point where the umbilical vessels are just entering the abdomen. So this is the umbilical cord insertion, and this is part of the vessels which are in the intra-abdominal part. So we can put color also and see, but here you can see it even in the 2D image very clearly. So once the tine reaches there, we usually advance the tine at about 6 millimeters beyond the center point where we want to coagulate, and then open the tines, and the current is passed. And that leads to coagulation, and so the vessels are occluded. So what are the settings? We set the temperature around 100 at 150 watts, and we put the duration for 2 to 3 minutes, depending on the size of the baby. And as coagulation occurs, you find that this whole area is becoming hyperechogenic or white. And before we're drawing the needle, we see that the fetus is having either severe bradycardia. We also put color on the loop of the cord to see that the flow has ceased. We check the cardiac activity of the other twin, and then the procedure is done. So what do we do next? We check the cardiac activity of the remaining twin the next day and do the middle cerebral artery peak systolic velocity. Because while the procedure is being done, it takes some time for the umbilical vein and the artery, all the vessels to be coagulated. So there's always a small risk of interfetal transfusion. So if there is interfetal transfusion, then the surviving baby may have anemia and will show raised MCPSP, and then they're followed for routine antenatal care. So it is a procedure which is worth doing because it increases the survival and also increases the gestational age at delivery. So it improves survival of at least one baby. So other indication that we use it for is a trap. And in this video, you can see there is a big trap fetus. You can see a lot of edema and sort of malformed baby. And here again, we're using radio frequency ablation, and the needle is put through. We put color to mark the vessels. You can see 2 vessels here. Usually they have 2 umbilical vessels, single umbilical artery. So once the RFA needle is here, and you pass the current through the tines, and then at the end you find that there is no flow, so the procedure is over. We usually do the cycle once for 2 to 3 minutes, and if the flow is persisting, we may re-advance the needle to reposition it closer to the vessel and do the procedure again. And we have never had to repeat thrice. We've usually managed with doing the thing twice.
Thank you, Dr. Vatsala, for those wonderful videos. Dr. Chandalula, could you tell us that what are the different management options for TRAP and
Yeah,
at different
so
gestations?
yeah, so actually it depends on the size of the trap. So if it's a small trap with very less vascularity, then you may not need to do anything and expectant management can be offered. And if it's a larger trap, so we look at the CRL of the trap versus the CRL of the pump fetus. If it's more than the two-thirds or 75% of the CRL, then that's a large trap. And if the blood supply is high and if the pump twin is showing a little bit of compromise with polyhydramnios, then we would need to treat it. In the earlier days, we would treat it after 16 weeks, but now with earlier detection, we are treating it earlier at around 12 weeks with interstitial laser. And so it can be given at an early stage as early as 12 weeks. Otherwise, it used to be after the obliteration of the coelomic cavity, because telepus was an important problem that used to develop once the coelomic cavity was not obliterated. But with intrafetal laser, that is much simpler now, and it can be done at an earlier stage.
Thank you, sir. So you've already highlighted what are the indications for treatment. I would request Dr. Vatsala to take us through a case of bipolar cautery, wherever it is used, how it is used, and the procedure.
So these are bipolar forceps similar to what you use in endoscopic surgery, but they're much finer instruments. So this is a bipolar forceps, which is around 2.4 millimeter in size with a trocar of 2.6 millimeters. And it's been used for a discordant monochorionic twin. So you can see one of the fetus has marked ventriculomegaly. So we had to reduce this fetus. So under ultrasound guidance, we introduced a trocar into the amniotic cavity of the fetus to be reduced. Again, we try to avoid the placenta. Whether we're doing RFA or bipolar, we should avoid rupturing the intertwined membrane also. So we have to be careful about that. So once the trocar is in, so this is us showing the entry of the trocar into the amniotic cavity, and this is the fetus to be reduced, and we are targeting to hold the cord closer to the fetal insertion. So we're very sure that we reduce the fetus we want to reduce and we don't hold the cord of the other fetus, which may happen by accident. So once the trocar is inside, we put in the bipolar forceps and advanced it to hold the cord. So once you've held the cord, if you move the forceps, the cord moves with it. And once you have held the cord and you put sort of Doppler on it, color Doppler, you'll find there is no flow. That means you are holding the cord and you've occluded it. Then you pass a bipolar current. So we usually set it around 20 to 30 watts and give pass current in small spells of few seconds. And you can, like you saw, there is like bubbling occurring and the whole cord becomes echogenic and there is no flow.
So which procedure would you choose, whether it's RFA or bipolar? How do you decide, Dr. Vatsala, on the procedure?
So there are disadvantages and advantages of both the procedures. So if you're using bipolar, you use after 18 weeks of gestation because it's a bigger instrument, more invasive. Whereas RFA, you can even use for 14 to 16 weeks fetuses. And again, you cannot use a bipolar if there is no LICA, like in the stuck twin, we used RFA to reduce in the SFGR. We couldn't have used the bipolar. And when you have very short cord, as in trap, or a very thick cord, as you have in hydropic fetuses, bipolar may not be a good choice because the prongs of the two prongs of the forceps can only hold a cord which is around 15 mm thick. So very thick cord, it will not be able to hold, it may slip and it may not coagulate all the vessels. The advantage of bipolar is that it simultaneously occludes both umbilical artery and umbilical vein. So all the vessels are coagulated together. So the chance of fetal bleed from the surviving to the dying twin is much less. So that is one big advantage. And often it all depends on the preference of the surgeon and the availability of the instrument.
So, Dr. Sineesh, what are the complications associated with these procedures? And how would you compare RFA with bipolar? Which is better?
So the prenatal procedures, therapeutic procedures have the common plights. You have the PPROM, you have the vaginal bleeding, abruption, chorioamnionitis, and maternal bleeding, preterm delivery, demise of the fetus, and surviving fetus. Now, of the two procedures, as Vatsala Madam has pointed out, bipolar cord coagulation is associated with combined occlusion of the artery and vein, and perhaps is associated with a better outcome. But a systematic review, which has been done in this, which has compared these two methods, has found that there is actually not much difference. And in fact, the use of bipolar cord coagulation has a slightly trend towards improved live birth rates and overall survival. But the incidence of PPROM is significantly higher compared to radiofrequency ablation. So of all the things tabulated here, the most significant association was the association of PPRM with bipolar cord coagulation.
Thank you. And of course, the surgeon's choice becomes very important. Thank you.
Yes.
Dr. Chandralula, could you tell us the most important thing we've been talking about is the neurodevelopmental outcome after selective feticide in monochorionic. So how does it stand with different procedures?
Yeah, so with all procedures in monochorionic pregnancies, we do expect and we do counsel our patients for neurodevelopmental problems that can occur from between 10 to 20% of our patients. So even if you do laser photocoagulation in TTTS, you can expect about 10% in the survivor. With fetal reduction, as you can see here, there can be neurodevelopmental outcome problems in about 6 to 7%. There is no consensus yet on what is the exact long-term neurodevelopmental outcome after a reduction procedure, because it's very variable depending on the gestational age that it is done. The earlier it is done, the better it is. Depending again on the procedure that is involved, as you can see, bipolar cord coagulation versus laser. And so all these variables are there. Again, the outcome variables. So some people do proper neurodevelopmental studies and some have not done proper neurodevelopmental studies, the Bailey score, etc. So there is a lot of confabulation and contradiction on what is the exact percentage, but roughly anywhere less than 10% is what is acceptable neurodevelopmental impairment in very, very long-term studies.
Thank you. Thank you so much, Dr. Chandralula. So why does IOFT occur, Dr. Vatsala, after the procedure? What is the reason for this?
So like I earlier discussed, that when you're doing the occlusion, both the vessels may not get occluded together, or it may not be complete occlusion. So while the procedure is happening, some fetal hemorrhage may occur at that time. So that can lead to either neurological damage or fetal death. Again, entanglement of cord, especially if you have ruptured the membrane, intertwined membrane, and amniotic bands can also form, which can also lead to death. So we also had a case of amniotic band following a bipolar cord occlusion, which led to a lot of edema and ischemia in the limb of the fetus. Fortunately, it did not sort of amputate the limb.
Thank you. Thank you, Dr. Vatsala, Dr. Chandralula, for those wonderful answers. Dr. Sineesh, we now move on to Dr. Vivek Krishnan to take us through twin-to-twin transfer.
Thank you, Dr. Emma. Can you see my slides, please?
Yes, can you come on full screen, please?
Yeah. Okay, thank you. Good evening, everybody. Because we're running on a very tight schedule, I would go straight to my slides without much ado. I've been asked to present a case of twin-to-twin transfusion syndrome. So what I've picked up a few videos that I thought were clear. So this is an illustrative case example. This is not one case. You might find videos from different cases, but I've selected videos that are clear so that you get an idea of what exactly the procedure entails. So this, for a demonstration, is a 32-year-old second gravida, previous FTND, 7 years. She came at 22 weeks. She was referred at 22 weeks and 2 days with as a case of monoamniotic twins with polyhydramnios. Nothing else was significant in the history. She had a first trimester scan, which was low risk, and the NTs were concordant. Now, if you see this video, it would, of course, at first glance, look like a monoamniotic twin pregnancies because you see two fetuses, one bigger than the other, and both seem to be in the same sac. But if you look close enough, you would see that the membrane is there and that's stretched over this small twin, which has hardly any LICA there. So this is a monochorionic diamniotic twin pregnancy with severe oligohydramnios in one sac and polyhydramnios in the other sac. And this is what perhaps a drawing of the same would look like. You can see that the membrane is wrapped around the smaller fetus like a cling film. The other fetus is happily playing around in plenty of fluid on the other side of the membrane. If you actually measure the Lycus, the oligo sac, as you can call it, had a measurement of 1.95 centimeters, whereas there was 13 centimeter Lyca in the polyhydramniotic sac. The growths were also discordant. The smaller twin was smaller by 28% compared to the other one, as is seen again from this growth chart shown here. And not just the growth, the bladders were also discordant. You could see a large and nice bladder in the recipient, so-called recipient twin, and effectively no bladder in the smaller twin or the donor twin. Dopplers, however, were concordant at this point in time. There was nothing to suggest a badly abnormal Doppler in either of the twins. So we have a case where you have a discordance in Lyca, oligo in one sac and poly in the other, with absent bladder in the smaller fetus. So this would classify this as a case of stage 2 twin-to-twin transfusion syndrome as per the age-old Quintero staging. We also got an echo done for this TTTS, as we do for all our TTTS patients. This baby showed significant, the recipient showed significant biventricular hypertrophy, but of course the CHOP score, the Philadelphia score, was not too bad at 3 for the recipient, for the pregnancy. Cervical assessment showed, of course, the scan is not complete in a TTTS case without assessing the cervix, and the cervix was 2.6 centimeters in length, so this particular case did not require a cerclage at this point in time. The Quintero staging, we all know, is not representative of a progression in the evolution of TTTS. It's rather a difference in the presentation that you would see across the different stages. But generally, if it is above stage 2, is when fetal therapy would be indicated. Stage 1, the optimal management of stage 1 is still controversial. Some people say you do offer laser. Some people say just wait and watch. You might probably get away even with a small procedure like amnio reduction towards later gestation. But if it's stage 2 and above, there is certainly an indication for fetal therapy. And the procedure of choice in TTTS, as we all know, is a fetoscopic laser occlusion of the anastomotic vessels in the placenta. So this is exactly what was offered to the couple. Of course, we put across all the numbers that you see on the screen to the family, highlighting, of course, on the fact that if you do not intervene, there is a 90% risk of losing both the twin and the pregnancy as a whole. But if they go ahead with the procedure, you have at least 70 to 80% chance of saving one, if not a 40 to 60% chance of saving both the babies. Now, this, if you compare with the risks that could be there as associated with the procedure, then of course we are certain that the benefits outweigh the risks. So this was explained to the couple, and they rightly chose to undergo the procedure. And once the patient decides on undergoing a fetoscopic laser, we do a very careful mapping of the pregnancy. We do assess the site of the placenta, the extent of the placenta from the top to the bottom, which quadrant or which segment of the abdomen it is occupying, whether it's in the anterior wall or the posterior wall. We then map the two cord insertions, very, very important, because your point of entry would be determined partly by the cord insertions of the recipient and the donor. You also try and assess the lie of the donor, because we believe that the intertwin membrane would be parallel to the long axis of the donor. So these are the things that we would want to map while we do a sonographic mapping of the pregnancy. You can either make a picture like this on your ultrasound and save it, or you can keep a drawing by the side and mark it with pencil or drawing paper so that you know exactly where your cord insertions are, where the donor fetus is lying, and how the membrane is likely to be, so that you can orientate yourself when you would want to plan entry in this particular case. Now, the setting, the procedure is performed in a sterile operating room. You have the patient's couch, the surgeon standing by on one side, you have an assistant on the other side, a scrub nurse. The anesthetist is always preferable if he or she is around, because we do this under local anesthesia, but with IV maternal sedation, and it's always a calming experience when you have somebody standing at the head end of the table. You would also need a good quality ultrasound machine. And of course, the fetoscopy set, I would come to details of this in subsequent slides, and the fetoscopy cart, where we have a monitor, you have the scope and the camera system that's there, and you can also integrate your laser machine into the cart, or have it separately if it's not an integrated system that you use. Now, the fetoscopy cart and the ultrasound machine are placed opposite to the primary operator. Now, first you need to scan the fetus and identify which way you would want to enter, and then you decide on where the cart and the machine is placed. So if the operator is standing on the right side, the probe and the ultrasound and the cart comes on the left side, as you can see here. Now here you can see that the laser machine is placed separately from the fetoscopy cart, and this is the ultrasound machine, and the surgeon stands right opposite the table. So this is the laser machine that we use. This is the diode laser. This has got an additional functionality called as LPS, which means it will not burn if you touch tissue. So if you accidentally go and hit the blood vessel with your laser fiber, the laser is not activated. So that is an additional protection so that you don't burst open the blood vessels by touching them and directly coagulating the vessels there. And that's the instrument set that you have, and that's the fetoscopy set all in readiness. So to take a glance at the fetoscopy set that we use, you have a 10 ml syringe that's for injection of the local anesthetic. We use a number 11 blade with the Bart Parker handle to make an incision through which the rest of the instruments go through, including your 18 gauge needle for amnio infusion if required, or also to guide your guide wire to introduce the trocar that goes in next. So we usually follow the Seldinger's approach to sight the fetoscopes. So you introduce a set from Teramo. Now this is the introducer set. This is guided through the 18 gauge needle. The guide wire goes in first, and then you pull out the needle, and then through the guide wire, the fetoscope goes in, the trocar sheath goes inside. You take out the trocar, leaving the sheath behind in place, and then through the sheath, you push in the fetoscopes. Now this gives you the advantage that in case you need to take out the scope and clean the lens or the tip of the scope, you can do it multiple times. The other option is to have a direct entry. If you do a direct entry, you cannot take it out and put it back in. So we always prefer to go with the outer sheath of the Teramo trocar sheath and then push the fetoscope through that so that you can take it out as and when required. Now these are the sheaths that we use. You have a straight sheath for a posterior placenta and a curved sheath for an anterior placenta. And there is a flexible 2 mm fetoscope that goes into either of these sheaths. That's the lens that you see at the other end of the telescope. This is a long straight telescope that's flexible that can go into both of these sheaths. We also use a 600 nanometer laser fiber that can go through one of the ports here. This is a 3-port sheath that we use. One is for the telescope, the other is for irrigation with saline or warmed ringer lactate, and the third port is through which the laser fiber can go in. So it's a 3-port sheath that is being used. Now this is how the telescope would look. It's a long and straight instrument that is flexible. That's the other end that is there that has the lens, and this is the light. This is the point to which the light source is connected, and you can see the 3-port sheath that's with a double lumen through which the irrigation as well as the fetoscope and the laser fiber can go in. And so this comes with an obturator. You pull out the obturator at the start of the procedure, and then into that space goes your fetoscope. So the obturator comes out, and into that space the fetoscope goes in. To the telescope, to the other end, you connect the camera, and then you adjust the white balance and the focus. Of course, the light source has to go in there before you do that. And then you're set with this part of the instrument set. So then comes the most important set of the step of planning the entry, because remember, this is the procedure where you get to go in only once. If your first entry is wrong, then you've completely sabotaged the procedure, and there's no choice for you to come in. I mean, of course, you can do that, but it's definitely not recommended to go in a second time. So your first entry has to be the right entry. So you need to plan this entry very, very carefully. As I said, there are 2 options here. One is to go with a direct entry fetoscope. Now these operating sheaths would be sharp at the tip, so you can directly enter. You don't need a guide wire or a Seldinger technique. But the problem, as I said, is once you're in, you cannot come out. Whereas with the Seldinger technique, you use an outer sheath from that's a flexible silicone sheath through which the fetoscope can go in and come out as many number of times as you want. Now, the entry point, as I said, is very, very crucial here. The idea is to occlude the blood vessels at the vascular equator. Now, the vascular equator in turn is expected to be parallel to the membranous equator. The membranous equator is in turn parallel to the longitudinal axis of the donor fetus. So as I said, the donor fetus is wrapped as you would wrap bakery items with a cling film. So the fetus is wrapped with a membrane here. And if the fetus is lying in this direction, you expect the membrane attachment to be in that direction as well. And of course, the vascular equator would be a little parallel to that further ahead into the most often into the recipient sac, but also sometimes on the other side of the membrane. So your idea is to go midway between the two cords, because that is where, in most cases, you would expect to find the vascular equator, and you would use the long axis of the donor, because that will be a guide that will tell you how the membrane is supposed to be. And we said the membrane is parallel to the vascular equator. So if you go targeting your membranous equator, it's quite easy to identify and trace the vessels that come down from the membrane and out into the formation of the vascular equator. So that's how you plan your entry. I hope I have not confused you much. I'll give you one more illustration. Now this is the uterus, this is the placenta, there's a posterior placenta. This is the longitudinal axis of the donor fetus. So you expect the membranous equator to be parallel to that, and further ahead onto the polyhydramnium, onto the recipient sac, you would expect to see the vascular equator as well. So I mark the point on the skin of where the donor's cord is inserted. I mark a point here as to where the recipient cord is inserted. So if I know if I go midway between these two cords, I would be in the zone of the vascular equator. Then my focus is on directing the fetoscope in the right direction, and there my direction of the fetoscope would be guided by the perpendicularity to the vascular to the membranous equator. So I go in between the two cords, perpendicular to the longitudinal axis of the fetus. So I'm perpendicular to the membranous equator, and then from there I slide out to see the vessels and identify the vascular equator. I'll show you a video of this as well. So this is how the scope enters. You can see this is the placenta, there's the posterior placenta, there's one fetus on this side, the other fetus on that side. I go between the two. This is where I would expect the vascular equator to be, because the recipient's cord insertion is here, the donor's cord insertion was here. So midway between the two cords and perpendicular to the long axis of the donor, in this case, you would expect the membranes to be wrapped around the donor like that. So your membranous equator would be somewhere here. The vascular equator is expected to be somewhere around the side. So that's the guide for you to angle your fetoscope and target the equator of the placenta. Now, if this is a view from the top, so once you've done the entry, once you're inside, your job is to map the placental blood vessels. This again, there are two options to do it. One of two routes that you can take is to target the membranous equator, the attachment of the membranous equator, identify all the vessels that come out of the membranous equator, and then trace them further ahead till you find an anastomosis. So you can direct your scope towards the membranous equator, trace the membrane from one end to the other, and then trace all the vessels that come out of the equator and trace it till you find an anastomosis. So if you find one anastomosis here, the vascular equator is roughly going to be along this line. So you carefully go from one end of the placenta to the other end, tracing all the anastomoses that you see in the way. The other option is to target the recipient cord, because you're going to enter the recipient sac from above. Now this is a view from above. Remember, you're targeting yourself towards, you could target yourself towards the recipient cord and then trace the leash of blood vessels that come out from the recipient cord till you find an anastomosis. And that will be your lynch point to identifying the vascular equator. So from there, you start looking at all the other blood vessels and identifying all the vascular anastomosis there. So you form a map in your mind as to where the anastomosis and how many of them are there, which is large, which is small, and so on and so forth. And then you go about doing the laser coagulation. Now, this is an actual video of how you identify the membranous equator. You might find some turbidity as you go in, but when you push in some fluid, it becomes clearer, and of course it becomes clearer as you go towards the placenta. So that's the placenta on the posterior wall. You can see the membrane as a shining, glistening layer there. So that is your membranous equator. And once you identify the membranous equator, that's the membranous equator there. You see vessels coming out of the membranous equator from the donor side to the recipient side. So then you trace each of these blood vessels till it leads you probably to an anastomosis somewhere down there. You can trace it all the way. You keep tracing down, down, down. Remember, arteries appear darker than the veins, and arteries always go above the vein. So that is the rule to identify an artery from a vein. You can trace it to the vascular anastomosis there. So this will be a guide to identifying the rest of the anastomosis along this line here. So this is your vascular equator, and then you keep tracing along this particular line. Now, the other option, as I said, is to go and anchor yourself at the recipient cord. So now I'm inside the recipient sac. I identify the recipient cord insertion, and you see all the vessels that go out from the recipient cord. You can keep tracing these vessels one by one. You can see the darker arteries going above the lighter veins, until you meet the anastomosis. See, this is the membrane in this case. You can see vessels coming from the donor side. You've been tracing from the recipient side, so you find anastomosis along the way, and that again gives you a clue to identifying the vascular equator. So one anastomosis should lead you on to the next, and you form a map in your mind, as I said, from one end of the membrane or one end of the vascular equator to the other end. You know exactly how many anastomoses are there. You keep repeating, you keep going one side to the other side, so you form a very clear impression, and you know which vessel to take and which vessels not to take. There is, of course, a difference between selective versus non-selective, sequential versus non-sequential. I think we have questions coming up later, so I would skip that part of the discussion. So once you've identified the vascular equator and once you've mapped all the vessels, then you go ahead coagulating. So this is an anastomosis where you apply the laser beam. If it's a big vessel, you start from the periphery and then go towards the center so that you don't, you can occlude it as you go and don't cause complications of vessel rupture. Now this is how it's done. You identify the anastomosis, you apply the laser fiber, and you apply the laser energy, and you can see it blanch. So this blanching will tell you that, of course, that vessel or the anastomosis has been taken. So this is proceeded in a very sequential manner from one end of the vascular equator to the other end. Now there are people who argue that you should be selective and sequential. You identify the AV anastomosis first, do that, and then go on to the smaller anastomosis. We will come to that in the discussion, as I said. So that's how the lasering is done. So once you've done all the vessels that you've mapped, you go back and review if you've missed any particular vessel. Very often, or more often than not, you would have missed some vessel along the way. So you take that as well. And then once you're sure that you've covered all the anastomosis, sometimes they might be at the periphery, sometimes on the other side of the membrane. So make sure you've covered all your anastomosis. And once that is done, you make a review and you're sure that you've taken all the culprit anastomosis. And then we go to what is called as the Solomon technique, which is otherwise called as dichorionization of the placenta. Now, this is to account for any minor small hairline blood vessels that you would have missed during your mapping of the blood vessels. So anything that you have missed during the mapping or missed during coagulation would be covered when you do a dichorionization or a Solomon technique. It's basically connecting the dots that you have coagulated. You would have coagulated multiple points. So with the Solomon technique, you laser from one end of the vascular equator to the other in a line, connecting all the dots that you have lasered so far, so that anything that's missed in between two anastomoses that you've taken is also covered. Now, this is how you go about lasering. This is, of course, an accelerated video. We don't do it this fast. For want of time, I've just accelerated the video. So it's how the lasering line goes, at the Solomon line that you draw from one end of the vascular equator to the other. Now, once the procedure is complete, then you do an amnioreduction from the recipient sac so that you can prevent preterm labor and PPROM because of the excessive distension in the polyhydramnionic sac. Now, this is day 2 of the procedure. You can see that there's already good liquor in the donor sac from 1.95, which is improved to 3.28. And of course, we did an amnioreduction to the recipient sac. So the liquor has come down from 13 to around 6.2. Day 5, you can also see that the bladders have become concordant. There's no longer a big bladder and a no bladder. It's equal bladders on both sides of the membrane now. Post-procedure follow-up, you scan them weekly for 2 weeks and then 4 weekly thereafter for growth and Dopplers. We do offer an MRI 6 weeks after the procedure to see for any intracranial changes because of shunting or because of incomplete occlusion. And generally, delivery is planned after 34 weeks, maybe around 35, 36 weeks for all our procedure patients. Now, this procedure is never complete after you've delivered the baby and you see the placenta and make sure that you've done the technique right. You identify all the blood vessels on either side of the membrane and see that you've done the anastomosis and the coagulations right. And it's always a very, very pleasant sight when they send you pictures of these babies 3 months, 5 months down the line. This is one of our early cases where we had a double survivor. It's always a very, very pleasant sight, as I said. Thank you. I had to hurry a little bit because Dr. Rima was after me saying to finish in 12 minutes, and I hope Dr. Rima have finished in 12 minutes, as you said.
Thank you, Dr. Vivek, for that wonderful presentation. We can just take on a few questions quickly with our panelists. So, Dr. Chandralula, Dr. Vivek has already described monochorionic TTTS and monochorionic twins.
Yeah, so Vivek has very well mentioned about the Quintero staging, which does not tell us the sequential situation of the fetus, but just the status at that moment. It also does not include a cardiac involvement, and that's where the CHOP and the Cincinnati methods have come across, which just basically adds the cardiac status put very briefly. So in the Cincinnati, you have three aspects in the stage 3, where you have mild, moderate, and severe Doppler changes. And this tells us what is the cardiac status. So it's an addition to the Quintero staging. And it's better to use the Cincinnati and the CHOP together with the Quintero.
Thank you, Dr. Chandrakula. Could we move on to the next slide, please? Yeah, so you've already spoken about the CHOP and the Cincinnati, but it's a little difficult to do it. A pediatric cardiologist would be required to carry out the CHOP. We may not be able to do this fetal medicine specialist. So Dr. Sanish, what are the indications for treatment when we talk of twin-to-twin transfusion? I mean, when do you decide when to intervene?
Yes, so Dr. Vivek has already brilliantly explained the treatment options for the same. And as of now, laser is a gold standard treatment for stage 2 to 4. And there was some doubt regarding whether what should be done in stage 1, expectant management, or one should go for a laser. And now the RCT data has come in this year. It has been published in the AGOG journal this year, which has shown that laser treatment is not useful in a woman with a stable stage 1 TTTS with long cervix, as long as she's asymptomatic. So for stage 1, yes, expectant management will be good. For stage 2 to 4, between 16 to 26 weeks, laser is a standard treatment for the same.
Thank you, Dr. Sanish. What are the different techniques? Dr. Vivek has already highlighted. It's the Solomon and the selective.
Yes.
So could you just tell us very briefly what it's all
Yes, so I think a description of the same is not required. Yeah, it has been beautifully demonstrated, but we had two techniques. Initially, we had the technique of selectively coagulating the anastomosis, and a lot of cases subsequently developed TAPS or residual TTTS, and the outcome was not that great. And following this came the Solomon technique, which is basically dichronization of the placenta, where after tackling the anastomosis, the dots are joined from one edge to the other edge, and you separate them into two different vascular territories. So though the postnatal outcomes or the neonatal morbidity or mortality is not very different, the incidence of TAPS and residual TTTS is very less, is significantly reduced when one uses the Solomon technique.
Thank you. Thank you. And what are the perinatal outcomes with or without laser, Dr. Sanish? Quickly.
Again, a stable, yes. The stable stage 1 TTTS, most of them have good prognosis unless they progress to stage 2 or up. And progressive stages, if no intervention is done, they have almost a dual mortality of 80 to 90%. With laser intervention, we have in good centers, that is in centers with at least 20 cases per year. Now the outcome is about 90% survival for at least one fetus and around 70% for at least 2 fetuses.
Thank you. Thank you. So Dr. Chandrakula, one final question. Can we do amnio reduction, and does it have any place in today's era, in the era of laser photocoagulation?
Ideally not. Ideally, laser should be the treatment offered in stage 2, 3, 4, especially between 16 and 26 weeks. But sometimes if the fetus presents very late, like after 26 weeks and you're waiting for delivery, you can do a standby amnio reduction. Or if you don't have fetoscopic procedure facility available, then at least that should be offered. But now with a good amount of centers available, I think photocoagulation is the method to be done.
Thank you.
And obviously, because of the complications of amnio reduction, which are far more in terms of long-term neurodevelopmental complications, are higher in amnio reduction, almost 20% vis-a-vis 10% with laser photocoagulation.
Thank you. Thank you for those crisp answers. And now I would request Dr. Suresh, the doyen of fetal therapy, to enlighten us with a wealth of his experience. Dr. Suresh, please.
Good evening. Thank you. I think we've had some absolutely fantastic presentations today on all the major complications of monochorionic twins. Just a few points to add. As far as selective FGR is concerned, the technique of selective fetal reduction is bipolar versus RFA versus laser. We have to understand that in some countries, selective feticide is not allowed by law. So there they resort to doing laser. In the laser, the challenges are the sac with the normally growing baby may not have polyhydramnios. So we might have to fill up, and also the sac with the SFGR may not have complete oligohydramnios. So the membrane will be dangling. So you fill up the sac quite significantly to push the membrane away to identify that. The second issue there is many times the smaller baby gets its blood supply from the larger baby's territory. So when you do the laser, you are actually cutting off the blood supply, and in higher incidence of intrauterine death of the smaller twin happens when we do laser. So that's why either bipolar or radiofrequency ablation is considered. Radiofrequency ablation becomes increasingly challenging as the gestational age advances. So at an earlier gestational age, it's good. And bipolar does not have the issue of baby getting twin anemia, polycythemia, or the other baby become anemic, which can happen if the radiofrequency takes a longer time to happen. As far as TRAP is concerned, a very important point is early interventions have been tried. That is in the first trimester, 12 to 14 weeks, but they are associated with very high mortality of the other twin, more than 50%. So at present, the general consensus among the fetal therapy group is not to do very early interventions. We prefer interventions after 16 weeks. And two things. One is interstitial laser. The other is radiofrequency ablation. Of course, you can do bipolar. And another thing which you can do is you can actually put in a 1 mm fetoscope and do a laser of the cord, because it's a very thin cord which comes out of the hilum of the trap. So we can do that. Now, the choice of the procedure depends on a particular case, because it's not always one procedure fits all, may not be there. There are some cases which are very amenable for one type of procedure. The same case, same condition may be amenable for a completely different type of procedure in that. So you need to keep your options open, which is the optimal procedure to optimize your outcome. And bipolar timing is, there's already said, it's after 18 weeks. Now, as far as TTTS stage 1 is concerned, for quite some time, the trial, randomized control trial, said the treatment is in equipoise, that is whether to do laser, not to do laser. So at present, the clear indications for laser of stage 1 is when there is very high distension, where there's maternal distress. You see both bladders, but there is oligopoly and there is maternal distress. Second is cervical length less than 2.5. So if these two are there, definitely laser needs to be done immediately. Otherwise, expectant management can be done, knowing fully that 60 to 70% of them will progress to stage 2. So we need to keep a very close watch. We need to do weekly monitoring, or in some cases even bi-weekly monitoring to do it at the appropriate time. So overall, the biggest challenge in all these procedures is the chance of premature rupture of membranes and the chance of preterm labor. So this is something which, whatever you do, you can do a procedure, 20-minute procedure, perfectly done. You come out very happy. Tomorrow she may rupture membranes. You do a procedure which is highly complicated. The mother's blood pressure is 150, 110. You've taken a great risk in doing a laser, and it's an anterior placenta, which has been very, very difficult. And at the end of the day, the babies can turn out to be well. So you need to counsel the parents adequately about the outcomes of these procedures. The last thing I want to tell you about the challenge of the anterior placenta. When the placenta is completely anterior, then accessibility, the window can be very less. So you might have to put the patient to one side or the other side, and then try to access with a curved scope. And sometimes at the edge of the placenta, you could have anastomosis, which can easily be missed. So there's a higher chance of a twin anemia polycythemia sequence happening with anterior placentas as compared to posterior placentas. So thank you very much for this opportunity.
Thank you so much, Suresh sir, for those wonderful tips. And I would like to thank all my wonderful presenters and panelists. It's been a great session. Thank you to each one of you for making it so interesting. Thank you so much.
After this brilliant session on twin fetal interventions, we move on to the last session for today, that is on total trial, that is tracheal occlusion to accelerate lung growth. Dr. Rima will be presenting. And our expert for this session is Dr. Pratima ma'am. I invite Dr. Sangeeta Gupta ma'am. She's Director, Professor, OBG at MAMC, and she's the one who established the fetal medicine unit at MAMC and Lady Hardinge hospitals, and multiple publications and research papers are there to her credit. And I also invite Dr. Bijoy K. Bala. He is faculty at various conferences, and I have seen people literally waiting for his lecture. His grasp on the subject is really commendable. Dr. Rima, please start your presentation.
Thank you, Dr. Poonam. So I would like to start that many years ago, a team based in Leuven, led by Professor Jan D. Prest, set out on an incredible journey with the help of a little balloon. This journey wasn't easy, it was long. And there were a number of times when along this, the topic of feto was inflated and deflated, much like the balloon itself. And finally, the journey reached its destination to evidence. Tracheal occlusion to accelerate lung growth, or the total trial. And the results have been very recently published in the New England Journal of Medicine. Now we need to understand that the problem in congenital diaphragmatic hernia is the intrathoracic herniation of the abdominal viscera, which impairs the normal airway and vascular development. The critical point in CDH is not the defect in the diaphragm, but the lung volume which is available at birth. And consequently, the condition is associated with high risk of neonatal death due to respiratory failure and pulmonary hypertension. For more than 25 years, researchers have been exploring this path. They've moved from open hysterotomy to repair of the defect intrauterine to clipping, and finally to the fetoscopic approach. In this procedure, the balloon is temporarily placed in the trachea to help expand the lung and reverse some damage that this anomaly causes. Michael Harrison did not get promising results way back in 2003. And it was then that Professor Deprest began his journey, his arduous journey of this little balloon. Now, this study was designed with the tracheal occlusion to accelerate lung growth trial, where 46 neonatal centers in 15 countries were involved. The hypothesis was that feto, compared to expectant management, followed by standardized postnatal care, increases survival to discharge from NICU. It was an open-label, randomized, multicentric, parallel group superiority trial. Now, in this case, the fetus were characterized by either severe or moderate hypoplasia. The lung-to-head circumference ratio is a sonographic measure to decide the severity of the disease in congenital diaphragmatic hernia. In severe group, the observed to expected LHR less than 25% classifies it as severe, and LHR between 25 to 34.9% irrespective of the liver, and LHR of 35 to 44.9 with liver down again qualifies as moderate hyperplasia. And we have calculators available on parentology to help us decide which category it falls into. Now, the primary outcome of this study was, in both severe and moderate group, was survival to discharge from NICU. And the secondary outcome, it was survival to 6 months without oxygen supplementation. Now here, 14 different fetal centers were involved. The fetus was assessed, eligibility tests done, counseling was done, and they were stratified into either the expectant management or into the severe or moderate group, which were offered feto. It was planned to remove the balloon at 34 weeks, and they were to be followed up by a standardized postnatal therapy. Now, coming to the procedure, it was a percutaneous approach. Maternal local anesthesia was used, and fetal was immobilized, and pain medication was given. Now, the trocar entry, as you can see, the fetoscope was introduced. The telescope is guided past baby's mouth, past the vocal cords, which is approached. This could be a difficult step initially to start with. It's advanced into the trachea, and once the correct anatomical position is confirmed, the balloon is deployed from the catheter and inflated with normal saline. And once the position is confirmed, the deployment catheter and the fetoscope is removed. Now, this balloon is left for 4 to 6 weeks in position. And then the next step is removal or unplugging the balloon. Now, this can be done either ultrasonographically, where a needle is inserted, the balloon is deflated, and then by the pressure of the lung fluid, the balloon is pushed out. And if that is not amenable that way, then a fetoscopic approach is used, where a grasper is used to hold the balloon, deflated with a needle, and then it is retrieved. So the aim is to increase the volume of the lung, which is the critical factor postnatally. Further management was by standardized neonatal management, and those babies where the balloon could not be removed intrauterine was removed postnatally. Now, if you look at the randomization, total this was started in 2011 February. A total of 1,300 women were carrying fetuses with congenital diaphragmatic hernia underwent preliminary assessment. 167 met the inclusion criteria. All the green that you see in the slides are all the severe trial, and all the black in the sleeves are all moderate disease fetuses. So they underwent preliminary assessment. 167 of the severe group met the inclusion criteria. 95 performed written informed consent to participate in feto. 47 underwent feto, and 48 women were subjected to expectant management. 4 participants withdrew. On March 3rd, 2020, the Data and Safety Monitoring Committee stopped the trial for efficacy at the 3rd interim analysis, and the enrollment was stopped. The results of 80 participants, 40 in each group, are the primary focus of the current study. In the moderate group, 196 randomized patients, 98 to feto, 98 to expectant, and they underwent interim analysis. As far as the baseline characteristics were concerned, there were no differences between the feto group and the expectant group, as you can see on the slide. Now, if you look at the primary outcome, in the feto group in severe CDH, 40% showed the primary outcome of survival at discharge, whereas in the expectant group, it was only 15%. So the relative risk was 2.67, which was definitely high. When you looked at the 6-month survival, again, the results were similar to the discharge from NICU in the beginning. Therefore, in the severe group, there definitely was an improvement with feto. But when this was compared to the moderate group, the results weren't consistent. This was performed between 30 to 32 weeks. And here, the relative risk was 1.27. So both feto and the expectant groups were comparable. Now, if you look at the secondary outcomes, again, at 6 months, moderate CDH did not perform very well with feto as the severe group had performed. If you look at the secondary outcomes, we see that the preterm premature rupture of membranes in the fetal group was definitely very high. It was 48%, whereas in the expectant group, it was only 11%. So the relative risk was 4.51. When we look at the gestation of delivery, less than 37, in the fetal group was 75%, in the expectant was just about 29%. So this was again high with the relative risk of 2.59. And if you look at the median gestational age of delivery, surprisingly, in the fetal group was 34 weeks and 4 days and 38 weeks, 3 days in the other group. And the median birth weight in the fetal group was 481 grams lower than in the expectant group. And if we looked at the secondary outcomes in the moderate CDH, we see that the late feto was definitely associated with high risk of membrane rupture in preterm birth. 1 in 5 live births occurred before 34 weeks, and this resulted in lower birth weight, though the number of babies who required ECMO were the same. If you look at the safety profile, abruptio was there in both the cases, both severe and the moderate group. There was one case of procedure-related placental laceration leading to hemorrhage, fetal bradycardia, and emergency cesarean section. There was one participant who moved away from fetal center, presented at 33 weeks, 6 days, and the balloon could not be removed, so there was neonatal death. There was tracheomalacia that was diagnosed at 10 months in one infant and was on oxygen ventilatory support for more than 240 days. So that was a poor outcome. And there were 2 cases of ventricular septal defect that were not detected before birth. So what is important is that it's not just the placement of the balloon that's important, it's also the balloon retrieval, which can lead to iatrogenic death and become extremely, extremely important. If you look at the safety and the technique, failed insertions were very less than 1%. Fetal position was a problem. They could not get the right position to put in the balloon. If you look at the removal of the balloon, 82% could be managed fetoscopically, 7% required an intrauterine rupture, and 11% were removed postnatally. There were a few cases of problems with genetics that was missed in the antenatal period and was detected only in the postnatal period. So if you look at the study, it had its own strengths. It was the largest trial in fetal history. It's a rare condition, but still large number of fetuses were taken in the trial with sufficient power to provide reference data for other studies. It was a multi-centric approach, and standardized assessment and management protocol should make findings translatable. Virtually, there was no missing data, and outcome is in line with the earlier non-intervention studies that were carried out. But like every other study, it has its weaknesses. The duration of the study was extremely long. It took almost a decade. Centers were not blinded to the treatment. We have short-term results, but no medium or long-term results are available. The numbers are still too low to document uncommon maternal and fetal complications, and outcomes cannot be compared to postnatal studies with different case mix. So what we conclude from the total trial is that it does demonstrate the feasibility of a collaborative randomized clinical trial. We can do it. In severe CDH, fetus significantly improves survival, which we saw, where the disease process itself is severe. However, in moderate CDH, the effects are less and non-significant. Feto is associated to a high risk of membrane rupture, almost 4.5 times higher than the expectant group, increased risk of preterm delivery over more than 2.5 times. And though maternal risks seem limited, we need to understand that balloon removal problems can be lethal to the neonate. So it just becomes a bottleneck as far as fetal therapy by feto is concerned. And long-term outcomes are required to assess the potential impact of prematurity. The analysis of the pooled data will definitely determine the effect of the duration of occlusion, and the findings of the study may not be extrapolatable to less experienced centers. So here we're talking of centers that have been doing fetoscopy more than 36 per year, and then 16 procedures when they start doing fetoscopy for the trial. So we still need that experience. But the question is that we have 1 in 4,000 CDH cases in our country. That's the percentage. 45,000 births per year, which translates to almost 10 to 11 cases of CDH per day. So even if half of them are terminated, what about the other half? So the question to be answered with the total trial is that is it time to translate feto from trial to clinical practice? So we have some experts with us who will take us on this journey.
So, Dr. Sangeeta ma'am.
Yes, Dr. Poonam.
Ma'am, what is the impact of this fetoscopic procedure on the pregnancy? What do you think there were, how much chances of having preterm, premature rupture of membranes and preterm delivery?
I think the figures have already been very nicely tabulated by Dr. Rima, and definitely though a p-value of significance was not calculated, but we can observe a very high incidence of preterm delivery and PPROM in these patients. What was remarkable was that the difference in the gestational age of preterm delivery was 34 weeks in the interventional group as contrast to 38 weeks plus in the non-interventional group. And probably the impact of prematurity was not much because beyond 34 weeks, the morbidity and mortality of preterm labor is much lesser than what it is before 34 weeks. So this is one point which I want to bring forth. So what of course, Rima has already told us the long-term outcomes of preterm have not been evaluated, which is very important because that has become an area of major concern, particularly the neurodevelopmental outcomes in these patients. The incidence of preterm and prom probably is also higher because you're doing two interventions in the patient. One is the insertion of the balloon, and the next step, when you have to remove the balloon, also most of the patients require a fetoscopic. So in every single patient, you are doubling the incidence of these complications. So this is what I have to say. And as far as your patients in the moderate congenital diaphragmatic hernia group are concerned, the total trial which was done for the moderate patients, we couldn't, that intervention was delayed. The classical period of intervention usually is proposed somewhere around 26 weeks, but here it was done between 30 to 32 weeks. And the premise for making this delayed intervention was to minimize the risk of preterm prom. But here we did not find any benefit. And on the other hand, the incidence of preterm and prom PPRM has increased. And maybe this is doing more harm than good. So we have to focus on strategies which would help us to decrease the incidence of preterm and prom. Definitely, Dr. Suresh has just told us it is not possible to completely eliminate it. And the interventions proposed are thinner fetoscopic instruments. And if one can go in for a device, because the balloon used currently is not patent for doing this procedure. It is actually used for endovascular procedures. So it is just an off-label use of this balloon. And if somebody can design a balloon which can be deflated by an ultrasound guided procedure, which would just use a very thin needle of maybe 18 or 20 gauge. And or we could have balloons which have magnetic valves and they can be opened up non-invasively. So we still need to evaluate these aspects, and a major focus would be to how to reduce the preterm delivery and PPRM in these patients. And the other thing would be to evaluate the impact of this premature delivery in this setting. Thank you so much.
Thank you, ma'am. Dr. Bijoy, sir.
Yes.
What are the fallacies and bottlenecks in the trial, and when you see it, especially in the Indian scenario? And do you think we should start in our country? Is it worth it?
I think thank you SFM once again for this opportunity, and also for bringing all of us together on a platform like this to discuss things, especially like this trial. And whenever there is something new, whenever a new procedure comes in to fetal medicine, it always captures our imagination, and we want to go ahead and do it. That's what we always want to do as fetal medicine specialists. But if you look at this trial is extremely good and it's done very well. But if you look at this trial claims to have a success rate that's above 40% for the severe group. But what we fail to realize is that in that same group, if you look at that table, you'll find that the survival or the morbidity in the severe group is also very bad when it is compared to the expectant management group. So what is being done in the severe group is that you're increasing the survival at the cost of morbidity. So the morbidity is directly related to prematurity. So in diaphragmatic hernia, the entire procedure is being done to save the lungs. But the biggest Achilles heel for the lungs is gestational age. So when these babies are coming out early, that is why you have an increased morbidity in the severe group in spite of their increased survival. Now in the moderate group, if you see, there is no statistical significance, but you can see that there is a trend towards improved survival. At the same time, there is a trend towards increased morbidity due to prematurity. So even in the moderate group, it will work if you go earlier. But if you go earlier, the survival will increase at the cost of morbidity. So the biggest problem that needs to be addressed here is how to decrease the morbidity and also improve the survival. And so that's the biggest problem here. So unless we learn to address that, it will be very difficult for us to start putting in balloons. And the second thing is that here in this trial, standardized postnatal care was offered for all the neonates. So how confident are we that our postnatal care can be equally standardized? That's another issue here. Then the part about the balloon removal, we need a fetal medicine specialist 24/7, available 24/7 in the place where this baby is going to deliver. So is that possible? That's also not possible theoretically. And yes, the magnetic valve for the balloon, which was described, I think 3 or 4 years ago in the fetal medicine seminar, it's just a balloon that's got a magnetic chip or something attached to it, and you just take the patient through an MRI machine and the balloon gets deflated. So that's something that can be used later on. So if the removal part is solved, then the problem comes only for the insertion part, and also the insertion part has to be earlier, less invasive, with decreased prom rates if we need to call this a success. But yes, this is a stepping stone, and I think we need to wait a little bit more, but maybe I'm being pessimistic here, but yeah, that's my opinion.
Thanks, Dr. Bijoy. Now, I invite Dr. Pratima ma'am for her expert comments and to conclude the session.
Thank you very much.
Welcome, ma'am.
Thank you very much, Dr. Reema. Thank you, Dr. Poonam. And thank you, SFM, for this opportunity. I've been listening very patiently for the last almost an hour from the pleural effusion thing. Well, total trial and management of diaphragmatic hernia is different to what has already been discussed, whether we are talking about transfusions, whether we're talking about pleural effusion and monochorionic with twin-twin transfusion. We have to remember that the condition, the diaphragmatic hernia condition itself is a surgical challenge. It is a medical challenge, and that itself makes the outcome for these babies a little bit more challenging than what it would be for a twin-twin transfusion syndrome or for a pleural effusion, because those babies don't require surgery after that, right? So we are already talking about a starting point, which is a much higher risk than the other conditions. So to me, this is pretty much incomparable to the other interventions that we're talking about. Secondly, the way the total trial, the design of total trial, the one thing for sure that has come out of the total trial is that a huge number of fetal medicine specialists can come together and conduct successfully a trial putting the fetal therapy along with the postnatal outcomes. And this is absolutely brilliant, right? I would not be so pessimistic in terms of saying that we can't do feto in our country. We probably could do feto, but that's going to take a good 10, 15 years. In fact, 15 years ago when I came back and was looking after monochorionic twins, I never imagined that one day I would do fetoscopic laser, nor so many other people would join in and do fetoscopic laser. So there's always a tomorrow that things might get better. But we have to also think about the condition, surgical condition. And when we are talking about, well, we know from the trial that it's going to work for only the severe diaphragmatic hernia. Severe diaphragmatic hernia, the prognosis with the, where the survival rate is 25% or less than that, you're increasing it to 50%. Honestly, how many parents are willing to go through a double surgical procedure where there is only a 50% chance that you could actually say, somehow save the baby's life, but still have the challenges of requiring postnatal, ECMO, oxygen dependency, and other morbidity associated with not only premature delivery, but also the lung condition. So this is something that one must think about before kind of embarking upon and saying, oh, we're going to start doing feto for all our babies. So yes, there are a lot of challenges. Nothing is impossible, but we have to be careful about how we're going to do this, where we are going to do this. And very importantly, I think Bijoy has already highlighted the postnatal, postnatal care that is absolute must when you do any fetal therapy, leave alone diaphragmatic hernia. In this situation, it becomes even more important because we are thinking about a surgical team, pediatric surgical team, and a neonatal ICU team, which is going to, and a continued neonatal and infant care, which is going to give these babies a better thing. In our excitement and our enthusiasm to offer fetal therapy and do things in utero, we must not forget at any point of time that these babies are, the parents are going to have to look after these babies postnatally, and we do not certainly want to create more morbidity in these patients. Then we are not doing any favor to our babies. So I think we are sitting on the fence here, more towards not doing active treatment in the near future. Also because very clearly the people who have done the feto have, even in the trial, are the ones who are doing at least 36 fetoscopies, a year. That means, 1 a week fetoscopy almost, which I think most of the fetoscopy centers in our country do not qualify for that. And secondly, at this moment of time, there is no training available to go and do your 15 fetoscopes. So all these things puts feto as a treatment option in our country on the backstage at this moment of time. I'm not saying it will not happen. It is very, it's possible that it can happen, but before embarking on that journey, we have to, be very, very watchful. That's my opinion.
Thank you, ma'am. Now we carry on.
My pleasure.
With Dr. Ashok Khurana, sir. You will carry on further for your expert comments.
Thank you. It's been a fantastic session. It's gone a bit beyond time, but it's gone way beyond my expectations. I am just so pleased that we have reached where we have reached, because we had to make a beginning somewhere. And we know that there's a fantastic amount of work going on in our part of the world. We know that there is some portion of this that perhaps is irrelevant because of our cultural approach to certain things. But the fact is that the Society of Fetal Medicine has made a beginning in this direction. I would like to start by answering the last question first, which is from Dr. Chelapan, where he says we need guidelines. These are under preparation. The whole idea of today's webinar was to introduce what we have done so far to our members. And we thought we'd start our executive committee webinar with this. And therefore, Dr. Poonam Goyal and Dr. Rima have put this together. Dr. Rima is leading our team that is putting together the SOPs, which is the standard operating procedures for this. And to answer the second part of Dr. Chelapan's question, a directory of where these procedures are available. We will have some sort of an auditing of what is being done where and put it on the Society of Fetal Medicine website. We promise you that. And I guess in another month or so, we should have all these procedures lined out in terms of how we do it, what we do, and so on. Congratulations to a fabulous webinar today. We have a few questions in the chat box, and let me take them from the beginning. And I know our experts are still with us. Thank you very much for being here. We've actually had the most phenomenal attendance I expected for something so specialized, and really fabulous speakers. We will exclude those questions that are based on diagnosis and concentrate on those that are actually based on actual the procedure itself. And to start with the intrauterine transfusions, there is this question from Dr. Nitya, and she wants to know the dose of vecuronium. And it was already answered in the chat box. It is 0.1 to 0.2 ml per kg, and that's what we will use. Now, the next thing is a practical question, Dr. Neha Gupta, and I want anybody on the IoT panel to answer this. Where do you send your KB test? Is Dr. Aparna still with us here? I know she has the answer to this. She's answered this on one of our recent webinars. Or Dr.
Chinmaya is there.
Yeah.
Dr. Chinmaya is there, sir.
Yeah. Chinmaya, where do you send your KB test? Do you do it in-house?
Yes, so we talk to our transfusion medicine persons and they help us by doing it for us case to case. Yeah. It is not available as a service per se, but they do the slides and they tell us whenever we want to.
Yeah.
Sir, I would like to add something. This is Aparna here.
Yeah, there you are. You have a poor connection
so
today,
sir,
Aparna.
actually KB test, if you actually want to do, this is a very... Yes, am I audible? Am I audible?
Now you are. Yes, now you are. Yeah.
Yes, I switched off my video. So actually KB test has a very, very, specialized indication to do, and most of the labs do not offer a standardized KB testing. Even in AIMS, when we discuss with our transfusion medicine people, it's a, something which needs to be standardized. So we really need to understand that when do we actually want to do the test over and above your normal feto-maternal hemorrhage. So the better methods now would be flow cytometry, and even, sometimes we do a rosette test, but very few labs would do it properly. So this is what I would say, that we need to have proper indications for doing it when we actually decide to do it. And because if you are in doubt, we anyways would be giving your 300 microgram dose of anti-D.
True.
In my hospital, can I just come in, sir?
Yes, yes,
so
of
we
course.
requested the pathologist. So it seems it takes staining the slide and then counting it manually below the microscope. The test costs only 300 rupees, but it is a lot of manual input. So
It's a lot of manual input and experience of the person doing it. So it's done on a case-to-case basis, on a one-to-one this thing. It's not offered as a service.
It's going to be done because I guess for flow cytometry, that's not going to be immediately available, because flow cytometers are shared platforms that the whole lab uses. So it's not that they can spare an hour for us while we get ready and we actually do this. I remember when I used to do the KB test, I used to do it on an OPD basis right here. And those days we were so enthusiastic about everything that it used to work. But now you can't get a pathologist to come and sit with you for an hour and say, okay, I look at it under your microscope. So we will have to find solutions for this in the near future. My next question is from, again, to Dr. Aparna. Dr. Dalia Rafat wants to know the tips for needle visualization and the tips for probe placement.
Yeah, so just I noted down a few points there. But the most important thing is that your tip should be visualized at all points. So that really depends on how you are putting in the needle. So the only thing that we need to understand is that your left hand and your right hand are in the same plane. So they should work together. So the direction in which your probe is placed, your right hand should be putting in the needle in the same plane. Also, no pressure on the probe. So that is something that is very, very important. And the third point is, do not put in your needle under the base of the probe. Just give some space between the tip of the probe and the needle. So 3 things I would really say that, they really work in localizing your needle. And by doing just amnio, you can perfect yourself to a level where you can do other procedures also. So do not enter without visualizing the tip of the needle inside the mother's abdomen. So one single thing that if you follow, you'll be all good to perfection, do your procedures to perfection.
Perfect, absolutely perfect. And the next question in the same category is Dr. Sumati wants us to explain the rate of hematocrit fall. I think Dr. Chanchal answered this in the chat box, but can you let us know again, please?
Yes, sir. So the rate of fall is, as we have seen, that after a first transfusion, it is usually 1% per day. So if you raised your hematocrit to 45 and you would want to wait it to fall to 30, so you would wait for 15 days before your next transfusion. But after 2 to 3 transfusions, when the adult blood has replaced the fetal blood, the rate of fall becomes lesser to up to 0.7 to 0.8, and that is generally seen, across transfusions. So this is what we generally follow. However, in a hydropic baby, in the initial part till the hydrops have settled, the rate of fall is much, much more, could be up to 2 to 3% per day.
Excellent. And then our next set of questions was on commercial vendors and phone numbers, and I think we exchanged enough of those in the chat box. So I will then move on to this wonderful concept of fetal pain. Dr. Manikandan, are you still here with us? Could you please tell us a little more about fetal pain and your recommendation for fentanyl? Anybody else to fill in while he is finishing his dinner?
Dr. Chanchal.
Yeah. So whenever we are doing an intrahepatic intrauterine transfusion or any other procedure which involves pricking the fetus, more than the usual invasive thoracocentesis or vesicocentesis, beyond 24 weeks, it is suggested that one combines the fentanyl with vecuronium. So the usual dose point, I think I'm forgetting the exact dose, but we mix it with Recurinum and push it through that intravascular.
It's 50 ml per kg, so 50 micrograms per kg.
And then a question from Dr. Deval Shah, and he wants to know up to what increase in hematocrit is desirable? What should be the aim? What should we aim for final hematocrit when we make our calculations?
Yeah. So Dr. Vatsala is here, sir. So, ma'am, Dr. Vatsala, ma'am.
Yeah.
So we usually increase the hematocrit to 45 to 50 in a non-hydropic baby. We don't want to go to very high levels, supraphysiological. We don't want polycythemia. So 45, generally 45, max 50 is acceptable. But if it is a hydropic baby or very small baby like a 22 weeker, then we should not try to correct anemia at the same time, because that much volume you're giving is going to cause a lot of hemodynamic changes in that baby, which the baby may not be able to tolerate. So we can correct the anemia over 2 transfusions.
Thank you. I'm so glad we clarified that, because there are papers coming in from the western parts of the country where they are overcorrecting this in the hope that they have fewer procedures. I'm not sure we can strain the fetal heart to that extent, and we really need more evidence before we try and economize in terms of the number of procedures. Dr. Vatsala, would you agree with me there that we have to be very, very careful with what the fetal heart can handle?
Yes.
Can I ask one question? Do you correct the hydropic fetuses in one go, or do you stagger your transfusion?
We
divide it into
over 2 to 3 transfusions.
So you divide it into 2, because procuring blood is a main issue. So,
but still, if it's a very hydropic fetus, if you correct fully, again, the baby is not going to tolerate all that stress.
So after 48 hours, because you get fresh blood, so you can transfuse.
So we'll do it after 48 hours, and depending on that, maybe another 48 to 72 hours. Depends on the post-transfusion hematocrit after the second transfusion.
The dictum is not to correct it more than 4 times.
But sometimes it is really bad. You have not corrected. Next time you go 48 hours later, you find that the baby has sort of, lysed. So the hematocrit has already fallen by 6, 7, 8%. Then we usually give a little extra, individualize accordingly.
Right.
Excellent. Next question is for Dr. Suresh to answer his own question, and that was the postnatal management for pleural effusions. Is Dr. Suresh still there? Or anybody from our pleural effusion team? Dr. Poonam Goyal, can you identify anybody who's still here to answer this question on postnatal management for pleural effusion and how do we follow them up?
Dr. Chanchal
is there.
So for postnatal effusion, sir, even if we have put in a shunt, because it's a chylothorax, and the problem is usually the abnormal lymphatic drainage, it keeps filling up. And when they put in a tube, although they put these kids on triglyceride-free diet and they supplement, once you put in a tube, sometimes it just keeps on forming. So the neonatologists nowadays,
one moment, we have interference from one of the attendees. If the attendees could please mute themselves. Yeah, thanks. Go ahead, Chanchal. You think you'll have to repeat a bit of that. Yes.
Yeah. So the postnatally, usually the neonatologist puts in a tube, and because it's an ongoing process, many times it just dries up on its own. However, if it doesn't dry up, they've tried sclerosing agents, varying from talc sludge to bleomycin to. There's no consensus on what is to be used. But usually the 3 cases that I've had experience with, they've all settled down. They've not created a.
Also, we have no idea how the neonate is going to respond to a foreign body, such as a sclerosant within the pleura. And we have no idea what the long-term is going to be.
So in literature, it's described, but my experience is limited on using of sclerosing agents postnatally.
Yes, and then there is a question on, this is from Dr. Jyotsna, on the utility of a shunt for a large macrocystic CPAM.
Well, yes, it is one of the indications, and especially if it is causing mediastinal shift in hydrops, it helps. Yeah.
Wonderful. There was another question from Dr. Hariharan, and he wanted to know MTP for antenatally diagnosed disorders. Well, that list is already coming up. SFM and FOXI had provided a list when we were putting the MTP Act together, and that list is already there within the rules. The rules have not yet been finalized. They're taking a while because of COVID season, and that is already going to be there. So we don't have to worry about what is going to be the list of anomalies. It's a huge list of anomalies. We actually made that list about 4 years ago when we originally first, 6 years ago. And I think we're going to use the same list. And that would be very, very useful for which ones should not be even touched at all because they're fairly hopeless. Then there is one question which requires little pondering over, and this was from Dr. Devasmita. And she said that she has a fetus with the duplication 22 fetus with a pleural effusion. And the mother thinks it's a very precious pregnancy and she would actually like anything done for this particular fetus. Dr. Vatsala, what would be your approach to such a thing? An abnormal fetus with a finding, how would you approach this situation and how would you counsel this patient? What would you do for her?
So if there is a chromosomal abnormality, I mean, doing this kind of procedures may be a relative contraindication, but then you have to sort of honor the wishes of the parents, explain, counsel, and accordingly decide if you need to put in a shunt.
Dr. Chinmay, what would be your opinion on this? How blunt would you be with the patient during counseling?
So we need to tell them that once there is a genetic problem, there could be outcomes could be different based on what is the genetic condition there. I would involve a clinical geneticist here, give the woman an adequate time to think over it. And if she is very keen on doing the procedure, like all other procedures, we would take a peer review. I would actually give her the option of talking to a few more senior colleagues, because this is a tricky situation. I mean, right now, the woman might be very emotional and do such a procedure, but suppose at the end of it, the outcome is bad. You are just, adding more trauma to her situation. So very extensive counseling is what we would do. Despite that, she wants to do the procedure. I think it's an individual decision of every consultant to do that.
Yeah, besides, duplication 22 is not really a syndrome we've identified so far. It could just be one of those lab situations.
Exactly, sir. That duplication 22 is something we are coming across very commonly in the QFPCR CMA reports nowadays, which we are obtaining.
Yeah. Yeah.
And it says that there is a chance of neurodevelopmental delay, which is why the patients get really, really worried about it. But we've had about 4 patients who've continued with that. And now, so far, no problems. So fingers crossed.
Yes, and some labs seem to give it a lot more than other labs.
That is true.
Yeah, so we will keep that in mind. And then a question on bipolar forceps, and Nitya wants to know whether we can use a 3 millimeter trocar with a 2.4 mm bipolar forceps.
Well, it has to be a good fit. Otherwise, I mean, your movements will be too free and the fluid might come out. So you have to use a proper trocar with the proper, I mean, it has to be for that size, it has to fit properly. So it's not that you can do anything with any instrument.
Yes, and it just certainly can't be loose hanging in there, and we can't struggle to push it in. And we do know that there is a tendency for some of us to actually want to reuse some of this, which can be very tricky because you wash it in hot water and that's the end of the whole story. And that can be fairly tricky. So we have an answer right there. Then there's this question of using the patch for preterm premature rupture of membranes. And Dr. Manohar Sivaswamy wants to know whether a platelet-rich plasma patch or an amnio patch, what is our experience with this and what should we be doing about this?
We've used it in our center, sir, but we've not got some great results.
Yeah.
There's too much chance of infection. The prematurity still continues, and we've tried it in about 5 cases, but we've not got good results.
Yeah.
So
I remember I used some in 2011 and I gave it up in 2011 because it really wasn't worth the effort. And if she didn't leak in 24 hours or 48 hours, she would leak in 72 hours anyway. So what was the big deal? And then we tried to do it for some of our very heroic, amnios that didn't go right because they were, there was a huge polyamnios when we did the procedure. And so it didn't really work. So I think we've pretty much, although there's a lot of literature that still keeps coming in from here and there, a lot of that literature comes in from Eastern Europe, and they have other problems. And so they like to publish whatever they experience in terms of 1 or 2 cases. We've come further ahead than Eastern Europe, actually. In India, we have people who do these wonderful cases. We have excellent centers. We have new centers coming up. And we have groups now that are working together. I mean, I know so frequently that Vivek comes and helps out at so many places just so that we can manage so nicely for our patients, because these patients are rare. So if we do find a posterior or urethral valve, for instance, we could all work as teams. So we'll avoid some of the literature coming in from some parts and try and make up our own literature in the future. In fact, for those of us who are keen to know, we have a second part of this webinar where we will cover the rest of the procedures. And we will work, Dr. Rima will work out the logistics, and then we will announce that webinar, which is the second part of the procedures that we haven't covered today. And one odd question on transfusions from Dr. Dhara Meena: if fresh O negative packed RBCs are not available, how much old O negative stuff can be used for transfusion?
So can I take this question?
Yes, please.
Yes, so I would say that, for one of our cases, we actually used cells which were 21-day old. So currently the concept of, the packing is such that, the oxygen carrying capacity, although it gets recovered after transfusion. So we have actually used 21 to 24 days old blood, especially for the case that we had presented, because the blood had come from Japan. So we did not have an option, but it worked well. The hemoglobin picked up, but on an average, what we normally do is use a blood which is 5-day old. But this has been our experience with using packed blood. And also the techniques of preservation now are such that, the preservatives which are used are very less. So even if your blood bank is confident and the blood is a bit old, you can actually do transfusion.
Yeah.
But now that blood was frozen and then used, but these are like prepared, it's lying in the fridge like that.
No, ma'am, that was not frozen blood. That was not frozen blood, because we could not freeze that blood.
No, under special circumstances, maybe what Dr. Aparna is saying is the upper limit of what you can use, but ideally it should be less than a week old. And most of the blood bank people would also advise you the same. Now, when it is not available fresh, most of the blood banks have a list of O negative donors. So whenever you are in a situation like this, it's prudent to quickly access all those donors, and very frequently they come across when they think it's a fetal transfusion.
But we did have issues during the lockdown when there were no donors, and I think that time we used some old blood and even the residents donated. So
yes, so you should keep a track for that's what we do. I am O negative, and we know how many people are O negative, so that helps.
Yeah. Our next question is a diagnostic question, and that is from Dr. Uzma Sheikh. She wants to know what's the cutoff for Momo twins categorization for polyamnios.
We can ask Dr. Vivek to take that question.
It's more about the bladder size, I think, in the Momo twins, because we can't really have a polyamnios
evaluation.
Oligoamnios evaluation.
Yeah. Vivek, what is your opinion on this?
Same, sir. It's quite difficult to categorize the Momo twin as being polyhydramniotic, because you really don't know what the limits are there.
And another question, can TTTS develop after 30 weeks? And this is from Dr. Jyotsna Panigrahi.
Yes, it can. There's of course an entity called as acute TTTS that can occur as late as even during delivery. Now, those occur suddenly, and it kind of signifies a major difference in blood pressures between the two twins. Having said that, I'm yet to see one in my practice. But there, of course, there's no scope for a fetoscopy there. Your only option is to time the delivery appropriately so that you can try and save both the twins. So it's prognostically much better than chronic TTTS. If you identify it in time and deliver appropriately, then you have both survivors.
True. And then one question from Dr. Dhara Meena: can we map the anastomoses by ultrasound?
Extremely difficult. There have been a few papers that have tried to do that, but remember, ultrasound is mostly two-dimensional ultrasound that you do. You get just one slice of the placenta. Even with a three-dimensional probe, even if you get a complete coverage of the placenta, it's quite difficult to do an ultrasound-based mapping of the anastomosis.
True. There's this interesting study going on, I think, by Professor Christoph Lees, where they're trying to do this high-frequency focused ultrasound treatment.
Yes.
So they are coming up with some data there. Maybe in near future we'll have something on those lines. But
but what he was referring to, what Christoph Lees is working on, is a high intensity focused ultrasound for therapy.
Treatment. And at the same time, the mapping is also happening by ultrasound only. So they're not doing any other invasive mapping in those cases. So they're taking a hypothetical equator and addressing that.
Yeah, there are a few tragedies on that. The equipment that is being used just cannot have that kind of a vascular frequency. So they're missing on a lot of vessels. They're presuming that all vessels will be superficial, which anybody who uses laser knows that is not necessarily true. There is a bunch of these vessels that is far deeper to the surface of the placenta than you and me would ever imagine. And we have seen this with ultrasound for a long time. And we know that, yes, HIFU is a great alternative. We also know that we're not sure about the safety as yet, the fetal safety of high intensity focused ultrasound. We are quite sure about the safety of MR guided focused ultrasound. The two are completely different in terms of their technology. And the Israeli technology is proven in fetuses to not have any teratogenic effects, at least in embryos and stuff like that. So we really have to be careful before we accept some of these technologies in our part of the world.
Still under trial, I guess.
Completely. And they're just working it out. And there's one person in the department that he's working on. And let's see what comes out of it.
Dr. Ashok, can I just come in? This is Pratima here. Just one comment I'd like to make. Yeah. I'm very apprehensive about this comment that was made by Dr. Aparna that 21 days old blood was used. And people are picking on that very quickly. I think that is one-off case. I don't think we should use old blood. I don't think we should use blood that has not been properly checked to give to fetuses, because here we are trying to do a life-saving procedure, and then there has to be a kind of focus and dedication on that. So let's not take just one-off case which might have been successful. For that one case, there could have been many other cases where old blood has been used and it has not worked well for the fetus. So please be very wary about that.
There are also concerns about stored blood becoming hyperkalemic over time. Yeah. So that can cause cardiac. We know
so
that
you can actually kill the baby by doing this, by giving the wrong blood. And this has happened in the neonatal units as well during exchange transfusion. We have to be paranoid about what we are instilling into the fetus. We have to be paranoid about it. And there is no excuse for that.
And one question which I would say we need to relate here is a straightforward answer on how old is old blood?
It has to be within 5 days. 5 days. You have list of O negative donors, use proper blood banks, and make sure that the blood is tested, is irradiated, and the fact that it is tested for CMV negative. If you don't have these facilities, don't do it, please. Yeah. Send the patient to facilities where they will give blood properly. I don't think that is difficult in this country, right?
And then there's
in
a question.
The enthusiasm to do things, we should not be doing wrong things.
Yeah,
right?
I
set
agree.
Wrong examples. Absolutely not. I mean, no wonder will be called as a cowboy country. I don't think we should, degrade our country to that level.
Yeah, and then there's one question for Dr. Chandralula. What has been your experience in the change of scenarios in intrauterine transfusions from when we started in the early 90s to where we are today? Is Chandra still here? I don't think he is here.
Yeah, Ashok.
Yes. Chandra, I wanted to know what has been your change in experience of intrauterine transfusions over the last 26, 27 years, 28 years that you've been doing it?
No, not much has changed.
Yeah. You have to unmute, Chandra. You've got muted. Yeah, we can hear you now.
Actually, the host is not allowing me to do it. Okay,
we've done it now. Yeah.
Not much has changed except that the numbers in major urban centers has reduced, and now it's shifted to tier 2, tier 3 cities. So we are seeing less and less numbers of RH incompatibility and hydrops coming in for blood transfusions. I mean, I probably do one in 2 to 3 months now, where we used to do once a week at the Wadia hospital.
Yeah.
So that's the only difference, not much. My one question to people who are doing a lot of transfusions is MCA Doppler as sensitive for minor blood group incompatibilities like the Kale and the others? Anybody having any experience with Rh positive mothers with minor blood group incompatibility?
Yes, it is. Anemia due to any cause, it helps.
Will be as sensitive.
Because we have seen a few non-immune anemias, which we identified only because of MCA Doppler.
Again, depends on how strong the antibodies are. So if it's a category A antibodies, the 5-6 antibodies that are known to cause severe hemolytic disease in the fetus and newborn, of course, the MCAs would show signs of fetal anemia. So it also depends on the class of antibodies and how strong that they are linked to fetal anemia.
And many times there are multiple antibodies as well in these fetuses, and not just a single antibody. So a complete maternal antibody screen is very, very vital as well to ensure, and also the blood that you give has to be screened for all the other antibodies.
Anyway, overall sensitivity is 95% of MCA Doppler. So we have seen a few where we see high MCA, then we do the sampling, you find hemoglobin is not that low, 11, 12, like that.
The reverse also, we have got normal MCA Dopplers and the baby is born severely anemic.
That
has happened to us recently, and that although not hydropic, but with hemoglobin of 5 and 6, and it's a little bit of an embarrassment when you keep saying
difference.
Could be intrapartum bleed.
Exactly. The time,
at the time of delivery,
the time at which you have done the MCA to delivery. What is the delivery? That interval?
Less than a week. We have been following up.
A week is a lot of time.
It's a lot. Yeah. And I think
even
MCA
during
is
delivery, like Madam said, abruption during delivery.
During delivery also can happen. Yeah, and transfusion through the cord. Delayed, early clamping, and a lot of things can change between doing an MCA Doppler and delivery per se.
Yeah.
So how do you explain the false positive MCAs?
False positive MCA. I think one of the things is it's a velocity, isn't it? So in such cases, we need to go see. One is the viscosity of the blood, which causes increased MCA PCA velocity. The second is the ejection. So we have to see when there is a volume overload due to higher ejection fraction, whether you'll have a higher velocity in such cases. So it's a combination of factors. It's not only viscosity which pushes up the velocity, peak systolic velocity.
Yeah, I would like to add to Dr. Suresh here, especially in diabetic mothers with fetal cardiomyopathy, you will get high velocities with normal fetal hemoglobin because of high ejection fraction. Also, recently saw a fetus with multiple VSDs with very high MCA Doppler, peak systolic velocity. So cardiac conditions other than anemia can cause false positive MCA positive.
I have a question to Vatsala ma'am or Suresh sir. That case with parvovirus infection, sir, it is written in theory that we should be doing platelet transfusion in addition to the RBC transfusion. Do we actually do it ever?
See, platelet transfusions are actually a nightmare. It's not that easy. It's got a very high complication rate in the sense that you need to match the platelets. You can't just give off any platelets that you have. You can't
and we don't get O negative platelets because platelets are usually random donors.
Exactly, random donors. So that's a major issue. Recently, I was having a discussion with John and Zarko on this, and they also said platelet transfusions is something, as far as possible, they try to avoid it because it throws up simply too many issues which are there. I remember at one point of time when I used to visit Queen Charlotte Hospital, they were doing 2 or 3 a week platelet transfusions for thrombocytopenia and other things. But a lot of reactions have come in that. Complications are high.
Thank you, sir.
Which brings us to the ultimate question of the evening. Do we have simulated training for fetal interventions
Yes.
beyond diagnostic procedures.
Yes. Simulation training is virtual simulation training for fetoscopy is now available from Canada. There was a person who had done his PhD on this, and then it is available, but it has not yet been put for regular use for everybody as a service. So somebody known, we played around a bit with that, but he has promised to work on it and bring it out soon for everybody to use. That's very soon. The second thing is semi-simulation is where a silicone model of the placenta with the vascular anastomosis has been made, and this has been done in Belgium, and where you can actually go and shoot the laser. So this silicone model, you can put it in a container, and you can put your actual scope through it and visualize it as you are doing. So for that, the problem there is you need to spend money on having a duplicate set of your instruments, fetoscopy instruments, which you can't use the same thing on a patient after that. So you use it only for that as a training. The third one is virtual reality training for amnio and CVS. There is one company in Chennai which has just in the finishing stages of that with various anterior placenta, posterior placenta. When you put the needle, it raises alarm when you go hit a vessel or train a vessel and all that. So it's in the final stages. That also will come through very soon.
Wonderful. That's good news, and hopefully we'll reach some of our people very soon.
Yes.
And Dr. Pratima, any closing remarks on these trainings? How do you think we'd be able to, if they become available, have some sort of a translation into availability in India? We don't need too many centers, but we do need some.
Of course, we need some, and we need scattered centers, and we need people who are focused in training, in obtaining proper training, and trainers and trainee both, of course, who are focused on it and then do their work. And definitely, if people are, talking about fetal therapy, we'd like to see their work as well as the outcome data, because then we are on a focused path. Coming together and working together is probably the way forward for people who are doing fetal therapy, because the cases are far and few. Standardization needs to be done, protocols have to be followed, and the outcome data has to be matched. And over a period of time, we are only going to get better.
Best is to put it on a registry.
Yes.
And look at the data.
Registry is always very challenging, Dr. Suresh, because, I think we have seen, trying to put in a registry, it's just too vast, the whole country, to bring in one common registry for everybody, where, we can, bring in together. But even if, groups start working with each other, I think we will achieve a lot in the coming years.
Yeah.
Well, we could take it as an SFM project to try and see whether a registry finally works. We've struggled with FOXY registries. We haven't had success. We've struggled with birth registries. Partial success, except that each one of us who saw the same fetus 3 times in the same town ended up reporting the same thing. But I'm sure there is a way forward, which we hope to achieve. With this, I'd like to congratulate the organizers for today's webinar.
One last question.
Yes.
How do you see the future of fetal therapy in India?
I think you're already seeing
Dr.
it.
Rima, please share the screen in between.
Okay, so I have to end with a note.
Yes.
नहीं पहले सर ने क्वेश्चन का आंसर तो दिया नहीं.
Okay, before everybody goes away. So count not the candles, see the lights they give. Count not the years, but the life you live. Sir has given us SFM, and the whole family of SFM is together to wish him a very, very happy birthday in advance.
Oh, thank you. Thank you very much.
ज़्यादा advance नहीं है sir, 1 ही घंटा.
Have a surprise, sir.
Yes, we have an hour left. That's very sweet of you. Thank you. Thank you. That is very kind, very touching indeed. Thank you very much.
Happy birthday, Dr. Khurana, in advance.
Happy birthday, sir.
Thank you. It's just an hour away now.
We'll wish again, but for the time being, happy birthday.
Happy
Thank
birthday.
you.
And so that was the vote of thanks for today, but I would still like to thank each one of you to be here. First of all, Saraswati Ma, because she allowed such experts to be all together on one platform. We had such a wonderful interaction. It was simply phenomenal. We thank Dr. Khurana who's always the mastermind behind these academic events. I thank our esteemed faculty. Dr. Suresh, he stayed back in Delhi for us. Thank you, sir. Dr. Telan Praveen, Dr. Pratima, Dr. Vatsala, and all my dear luminous presenters, Dr. Chinmay, Dr. Manikandan, Dr. Vivek, Dr. Sunil, Dr. Aparna, Dr. Chanchal. Thank you for this phenomenal day today. Dr. Poonam, we thank you. You're my co-host. So thank you for this rendezvous, which was great. And Vishalji, without whom nothing is possible. The Conference International for making this video. They helped me, and our trade partners, and most importantly, the delightful audience who stayed back, 120 in number, 105 at 11 o'clock at night. Thank you so much. Thank you.
One thing very special.
Sir wanted to say something.
Yeah,
Manjeet,
no, just special today. I didn't expect that. I'm just showing you something. Are you able to see? Are you able to see?
It's merging with your background,
No,
sir.
Oh, okay, I'll remove the background. One second. I'm sorry about that. Just 1 second. I'm just removing the background. Just wanted to show you. Yeah. 1 minute. Yeah. And,
That's releasing a book today.
Not releasing. Just now it has come out from the publisher.
Wow.
It is our first manual on fetal echocardiography. Mediscan manual of fetal ecography. So very soon you will get
congratulations,
to
sir.
see it. Yeah.
Congratulations, sir.
That's a treat for us also.
Yeah. Ashok's birthday and this has coincided.
Yes.
Thank you very much. That's very kind. Thank you so much.
So thank you. Wonderful. Absolutely. Today was absolutely delightful. And I'm glad I was here.
Thank you, sir. Thank you so much.
Bye.
Good night, and thank you very much again.
Everyone, good night.
Thank you, sir.
Thank you, sir.